meetings and are able to provide the input that we need to make our own decisions. So I think that's probably more of the thrust of.
Yeah. No, appreciate the point. Okay, Elizabeth.
Thank you. Just a clarification. It says that we'll be looking at considerations for settings of value in November, but I'm assuming we're going to be thinking about sort of health outcome metrics along with expenditure measurement throughout, because those will be different data sources in some cases. So in the planning, will we be looking at the quality and outcome and health metrics as well as expenditures? Because that will influence the design, I think.
So just wanted to make sure I understand your question. So like in terms of looking at quality and equity measures at the same time?
Correct, but
okay.
Those may not be in the claims metrics. So are we designing the data sources with that in mind?
Yeah, OCA does have activities related to developing a single set of measures for quality and equity that once you set the spending target, that you would also monitor quality and equity, workforce stability. And then so far, in the first slide, we did show some data points about quality not always being, or spending not always being linked to high quality. So in terms of setting of the spending target, what we will go over is trends in spending by market segments such as commercial, Medicare, Medicaid, and historical and projected, and then trends in economic indices, trends in other population-based indices. But any other supplemental information, at least the way we've approached it is that you would set the spending target and then monitor at the same time, but open to kind of hearing more of your thoughts on kind of what that would look like in terms of looking at quality before you set the spending target.
Yeah, Elizabeth, I think this is a really important point that I'm glad you raised it, because certainly waiting to introduce the concept of value till November is never, I think everyone's around this table. Rick, you led it off in the last meeting, and even the presentations were not about the lowest cost system, but the highest value one as well. So figuring that out, I think we could talk a little bit about that now. Certainly look forward to the conversations by the two presenters from the other states a bit on informing that, and then making sure that we keep this front of mind on how it drives the activities in every meeting, because I think I heard that resounding from everybody that we're not here just to focus on what is the bottom line cost of this health system, but are groups often overlooked getting what they need? Are we seeing the kind of quality that we know good systems designed certain ways can achieve today, and spreading that more broadly? So curious, maybe we can take a few minutes to hear thoughts on this. Elizabeth, go to you first, and then love to hear from everyone else.
Well, just one addition to what you said, which I agree with, is there are going to be several areas like primary care or public health where increased investment may result in better outcomes.
Yeah.
So if we're just looking at the spending limits, that we're going to need the other information to also look at investments, which will reduce total cost. And then just keeping in mind whether it's patient experience, patient reported outcomes, the other data sources that are going to be necessary to have those balancing metrics just in the design.
Yeah, I think I would just say this as we open it up. The activities of other states should be instructive but not determinative of what we're trying to do. And so with that ear and trying to understand what other people have done, I think pushing the points that you just made, Elizabeth, as well as I know others people around the table will make, I think will be key for us. Other thoughts on this, David Carlisle?
I couldn't agree more, Elizabeth. And I think this is one of the key missions of this board is to take that perspective and utilize the data that we have available to assess things like quality and equity in this process.
Sandra.
Yeah, I completely concur that the sooner we get into that conversation as we're trying to figure out the spend would make sense. I also wanted to just I know it's a dynamic plan, appreciate all the work Vishal's gone into it. I think the behavioral health spend is also something that we should not defer way into 2024. The overlap between primary care and behavioral health is enormous, and so how we integrate the behavioral health piece in the primary care spend, I think, as you think about the calendar and it's dense, I recognize, but I hope we don't wait too long to get into that.
Yeah, I'll just pile on a little bit too. I think the behavioral health spend is important in its formal sense, but we know a lot of behavioral health spend is actually out of pocket on the side because the systems don't all deliver it. So Elizabeth and Vishal, we're making your job a lot more complicated all of a sudden, but I think it's really important that we do understand we're kind of at the dreaming stage, right? Other states maybe grappled with the same thing and didn't have the data sets and didn't have the information to be able to do this. But let's put it all on the table and see what we can come up with by way of getting these really important factors. And certainly the two I heard that we raised at the last meeting, public health piece, behavioral health spend, obviously the primary care targets are going to be critical on the let's invest more to get the value in the rest of the system. Okay, Rick.
Thanks. And, you know, to the point that Elizabeth Mitchell raised, and seconded by David and Sandra, I would second the point that certainly we should pay attention to the extent that we can fit it in, and obviously we're deciding what we can fit in with help of Vishal and staff, that we should pay attention to the measurement part. What will we be measuring around equity, around quality? I do think we'd be fooling ourselves if we thought that at the time that we need to come up with a methodology for setting a spending target, GDP plus something or minus something or adjusted for population, et cetera. I think we'd be fooling ourselves if we thought that at that time we would also be able to include measures of quality or equity in that target. That if the target were, it'd be great if we knew that, at a 4.5% target, we could increase quality and equity by 20%. And that if we only have a 4% target, we're not going to be able to increase quality and equity. I can't imagine that we could be there. But paying some attention to, how we're going to be measuring, the really important outcomes, certainly makes sense to me. Although I know, Vishal, that this is already a very packed year, and kind of how that would get fit, how we would fit that in, is not obvious to me. But some attention earlier rather than later would make sense.
Go to Elizabeth and then Richard.
So I am all for as fast a pace as possible. I don't want to hold us up, but I do think there's considerable evidence showing, for an example, investment in primary care has a 13-to-1 return. So we want to make sure we are including the areas of investment, and then particularly thinking about hospitals as an example. We may want to be investing more in rural hospitals, but looking at targets or spending limits on other facilities. So just I totally agree. We can't hold this up, but I do believe that evidence will inform the nature of the targets.
Richard.
Thank you, and I appreciate the discussion. I also agree with Elizabeth's points about looking at the value, and I think David also mentioned equity, right? So we have a lot of disparities. COVID certainly showed those disparities, and so we need to recognize that we have too many Californians who may be under-resourced, not just in healthcare, but in other settings, right? We have a homeless population, et cetera, and how that then unfortunately, as I think about it as a balloon or a mobile, right? One place pushes on one other place, and then it ends up becoming, pushes on healthcare costs, right? Because that's when they don't get certain other services, it falls that way. So I certainly think we need to look at the equity as well as the quality value piece. And I know that just makes things more complicated, but at least we should be trying to figure out. I certainly understand that setting a cost target doesn't necessarily mean just moving it up. Doesn't mean that up suddenly goes to equity and quality, right? So that's not one does not necessarily directly lead to the other, but if we don't measure it, we're not going to be able to parse it out. I think as Elizabeth said, like, how as we look at the sub levels, eventually, we need to have those other measures. The other thing I'd also mention is, and I agree with the discussion about behavioral health. The other one, while I'm not saying we need to do this up front, we also need to think about the balloon analogy is long-term care, right? Because we have a lot of people parked in hospitals who are waiting for long-term care facility, or not just a long-term care institutional, but LTSS, which, by the way, is one of the fastest growing parts of the state budget, as someone who served on the budget committee. So, and of course, in Medi-Cal, we're already trying to incorporate the two, right? We're doing the coordinated care initiative. We're already trying to incorporate it into the capitation for Medi-Cal plans for severe. So it just shows you that, well, we could be trying to, what we don't want to do is while we're not going to micro at this point, putting a cap on cost, and then what happens is that pushes things into other places, right, that we're not measuring. And so, long-term care is one of those places that I'd be concerned about. But while I wouldn't say we have to deal with that right away, I think we need to be conscious of that. I certainly think behavioral health is so interlinked. It's really hard to say that we don't try to do that up front, unfortunately. And again, I realize the complexity of the work that it's involved, but the connection between physical health and the behavioral health is so interlinked. It's really hard to figure out how do you tease those out without doing them all at the same time.
Thanks, Richard. Ian Lewis, sorry, Ian, that I've been negligent to notice your hand is raised, but please jump in.
Not at all, thank you. And at the risk of piling on and making the staff's work even more difficult, and I really appreciate all these points, especially Dr. Gall, your laser focus on out-of-pocket spending. Two things that I've had a hard time separating out, especially looking at this timeline. One is, as we think about our methodology here, really understanding how out-of-pocket spending in all its various forms feeds into this as we hopefully realize some savings across the system that hopefully is going to impact some of the denials of care that are happening right now as a result of people needing to spend out of pocket. And that's a factor we all need to consider as we think about this. Secondly, I think I raised at the last meeting the question of when we're going to tackle matters of defining sectors. I know that comes later in our overall schematic, but as Elizabeth highlighted, for instance, rural hospitals, thinking about how we might approach sectors is going to be very crucial in my mind to thinking about the overall statewide measure.
Thanks, Ian. So seeing no other comments around the table yet. Oh, sorry. Right. Yeah. Your mic's not on.
I'm sorry. In the December 2023 meeting, we're going to be, that's sort of the last meeting, and then the data collection regs get submitted. It seems late in the process to have the first discussion of the payer administrative costs and profits. I would have thought that needs to be a little earlier, because presumably that will be in the regs. And if it's the first time we've talked about it, then kind of how does that work?
That's a good point, and we could take that back in terms of moving it up.
Okay, Richard, looks like another comment, please.
Yes, actually separate from, so one of the things I noted was, and I appreciate the letter from Health Access, and they submitted as part of public comment for the last meeting. One of the things they made note of is that especially as we're getting more from sort of this discussion phase to more decision-making phase, to figure out ways to agendize items that we might want to talk about don't just agendize the decision and the discussions. It all has to happen at one meeting, that we actually have an opportunity to talk a meeting before, get some feedback before we make the final decision, perhaps at a subsequent meeting. So in crafting agendas, allowing some space for that to happen, because clearly we cannot, we're not supposed to be talking about things that aren't on the agenda. So in fact, that was just rattled off at the beginning of this meeting. So creating that space for us to have some discussions about things that will finally result in decision, not just at the meeting that decision's being made, but perhaps a little in advance.
Great, thanks for that point, and agree, Elizabeth Landsberg, Director Landsberg. Two Elizabeths, I'm gonna, to Rich, geez.
Thank you all very much. So I just wanted to appreciate all of the discussion and also ask a couple clarifying questions. So I just want to be very clear that we fully agree with all of the comments about needing to focus on quality and equity as quickly as possible, and also needing to focus on behavioral health together with primary care. Candidly, a lot more work has happened in terms of and CHCF did a lot, in terms of defining primary care, and other states have done this. So we're a little bit behind, less groundwork has happened on behavioral health. And I actually have similarly pushed the staff to say, can't we do behavioral health at the same time as primary care? So and they, explained why that was harder to do. We will certainly take it back. I understand the point, and we know that many primary care providers are doing a lot of assessment and early intervention, and that there's a synergy that's very critical. So we'll definitely take back behavioral health and understand the importance of it. On the equity and quality measures, we've always known that if we wanted to look at value, we can't look at cost alone. We need to look at equity and quality. Can you help us understand a little bit better? So we have started discussions with our sibling departments, because DHCS, CalPERS covered, California, many other entities, DMHC have done a lot of work in identifying equity and quality measures. And I think we have taken our task as it should be a subset to not have the plans have yet another set of standards. Can you help us understand, Elizabeth Mitchell, you said you thought it was important before as the board is choosing a methodology for spending targets, that it's important to know what the quality and equity measures will be. And I just want to make sure I'm understanding that synergy fully.
Yes, and I think there's a lot of work that has been done on effective quality measurement, as you know. But looking at some of the levers, like investments in primary care, as an example, can improve outcomes, reduce unnecessary admissions. So that we're not setting an overly simplistic target that is just sort of across the board. How do we understand what interventions are actually improving health outcomes, improving equity, and having those balancing metrics, I think, will be important for that. And because we're talking about an APCD and a lot of that information won't be in there, just thinking about the other data sources that we need simultaneously.
And part of the challenge is the spending target is an enforceable target. The equity and quality measures and the primary care and behavioral health spend are all baseline that the board will set and will certainly measure against, and they're not enforceable. So there's a little bit of a difference, and I understand it's absolutely important to look at all of the pieces.
Before you go, Richard, Don, and then Richard.
I was just going to end, and maybe if I'm butchering what your point was, say so, please. But I think part of the concern that you're hearing is that as we do the spending work, we're constantly reflecting on how it bears on quality and equity. And so we need to kind of pivot to that. So we create a metric or a goal, and then we look at how it affects quality and equity. Because if we don't do that, the odds that we inadvertently do something harmful are probably really high. Is that?
Yeah, I think well said, Don. Richard Pan.
Yeah, I would also make note that the statute clearly says that we adjust the target by quality and equity measures. So while perhaps less applicable to an entire statewide target, certainly as we start talking about sectors and other things, as those mentioned earlier, those need to be adjusted for quality and equity. So, so it's very tied in the actual language of establishing this body that this needs to be done. So that's why it's so important we have those conversations. The other thing is I would also make note, it's certainly be very interested in seeing what information we have on definition of primary care. But, as a primary care physician myself in active practice, as a volunteer, I know there's barriers. So we talk about shortage of behavioral health, yet there's barriers to primary care physicians, helping deliver behavioral health in community health centers. And so, and so while we don't necessarily get into those kind of weeds, that does have an impact on costs when patients are forced to leave and then have to come back in order for us to support those kind of activities and things like that. So, and then people don't show up, et cetera. So there's lost opportunities. There's probably increased costs. It's possible that because they didn't come back, that now instead of getting the service, now they have to be a higher level service, which is expensive, et cetera. So, I mean, those are things that we won't get as much into specifically. We want to be sure we have the incentives that are structured in a way that allow, that actually support, advanced primary care, continuity of care. That's another thing that often gets missed out. The literature on primary care is not just about, oh, you have a primary care physician or other primary care provider. It's that you have continuity with them. They know you, that the patient knows them on an ongoing basis. It's not, so we need to be sure that those types of factors are worked in to that as well.
I want to get to the public in a second, but just to summarize, I think, team, we received a lot of really important feedback. I just want to also echo what you said, Elizabeth Landsberg, that DMHC, others are working on quality and equity measures in the health plan space, thinking about how to take the idea and implement them in an assessment over time. At some point, it might be interesting to invite our sibling departments to come to a meeting to present where they are, how they've been thinking about it, because they are also have the same data set limitations, the same concept. So at least we can get that sense. I know I have a preview of that in my other job, but I think it'd be helpful for everyone around the table and the public to hear a bit about that as well. So in agenda setting for future meetings, I know we have a plan, but I hear you, Richard Pan, that being iterative, making sure that what we grapple with here ends up showing up in our future agendas. I chair another board that many of you attend and think about as well. Sandra Hernandez, thank you for all your help there, where we have a style of getting to do some of that very effectively. So as we're kind of coming together as a team as well, I think we can adopt some of that.
Dr. Bailey, Vishal needs to finish agenda item 4 before we do public comment.
Perfect. Thank you.
I'm following up on a topic of discussion from the last meeting on public health expenditures. In March, the board discussed the issue of public health expenditures as it relates to total healthcare expenditures. I do want to note that the enabling statute doesn't include public health investment in the definition of THCE, and the definition of healthcare entities also does not include state and local public health departments. So, it is an issue of public policy importance, but at least from the staff perspective, there is some concern that it may divert from OCA's and the board's already significant workload. Just to cover on a few issues, exploring measurement of public health investment would require us to do a deeper dive. And these next set of slides cover these issues. In terms of the first set of issues, it's for defining public health expenditures. We would note that not all public health department budgets or expenditures constitute public health spending, or what we typically think of public health spending. For example, there's more environmental functions for air and water pollution abatement, sanitation, sewage, et cetera. Other expenditures are more germane to medical spending, such as for disease prevention programs. So, it just begs the question of how we would think about spending on these other categories, which can include vital records, operation of public health laboratories, oversight activities for health and safety, such as facility licensing and regulatory enforcement. And then also kind of this next bucket of measuring public health expenditures. Some initial questions we have are about the universe of reporting entities. Would this be state and local public health departments? What about the role of CBOs or community-based organizations, which do get state and local funding for service delivery? And there's also the role that nonprofit foundations and philanthropy play in supporting public health activities. And then lastly, next slide, please. I'll discuss how this interacts with spending targets. So as you know, spending targets are a tool to slow healthcare spending growth and improve consumer affordability, including public health spending and THCE would combine spending that is for the benefit of a broader population or community with medical spending for an enrolled population. And then we'd also need to consider how public health investment statewide or regionally factors into a healthcare entity's performance relative to the target. So these are just some considerations we've laid out. We're happy to turn it back over to the board for any discussion or questions you may have.
David Carlisle.
Thank you, Vishal, and I agree. This is a complex element for consideration. I think sort of implicitly it makes sense to include public health expenditures, and it's something that I think we'll want to return to as we consider this inclusion. I'm especially curious about how the other states have addressed this, and I know we're going to hear from two pace setters here, and I know that they've actually wrestled with this question. I think my sense is that this is an important consideration, an important element to consider, but others have been down the pathway before, and I'd want to see what their considerations were.
Richard Krenick.
Actually, if I could, a nomenclature suggests that I be Rick Kronick, and then there's only one Richard in the room. Vishal, I appreciate the considerations you've raised, and I'm aware of how much work there is both for us and for staff, and don't want to divert us from the main requirements, things we have to do. On the other hand, many of us and everyone in the field has been saying for decades that the separation of public health and medical care serves us poorly. There is the hope and I think likelihood that whatever the office and the board produce and reports on spending will get some attention from the public and from the legislature. And there is the kind of out of sight, out of mind problem that if we say that, we're not going to pay attention to public health spending, well, we won't pay attention to public health spending, and the public and the legislature be less likely to. I would suggest, as relatively simple and not particularly wonderful, but answers to your question, that the universe would be state and local public health departments. And I think that all local public health departments have, or all local counties have publicly available budgets that we could get what they're spending. It would not be apples to apples, as you point out. Public health department budgets include a bunch of different things in different counties. I don't think we should think that we're going to have, perfectly comparable data on the payer side. Getting sort of profits and administrative costs is going to be different in Kaiser and other health plans. Health plans that own medical groups, can put profits into the medical groups that then come back to the health insurer. So we're not going to have, perfectly comparable data anywhere we look. And I would suggest that the public would be better served by at least having as an adjunct to the total health expenditure data that we're proposing to collect from payers, some accounting of what public health expenditures are in California. Over time, perhaps it could be made better and more comparable and closer to what exactly we might want. But at least starting, it's probably going to be 3% of the total or something, and not ignoring it, which I think would be a mistake.
Thank you, Rick. Richard.
Thank you. I want to second what Rick said, Richard said. I do think, first of all, outside our mind is a big concern. But the other thing we have to make note is that, public health departments do provide clinical services. And while I'm not sure we need to put cost targets on them, we do acknowledge that, right? They do STI care. They do actually a lot of some mental health, et cetera. The other thing is the other things they do that may not be direct medical services often have an impact on health outcomes and also the need for medical services in that community, right? And when we talk about equity and so forth, I mean, if we just look at COVID and we recognize that states, places where public health was less effective, or perhaps I should say, where people discouraged public health actually had higher mortality rates and greater hospitalizations, we need to acknowledge that life expectancy varies by 20 years across the United States. There's area, that's how big the swing is, and some of that is related to policies related to public health, and either weakening or strengthening public health. So that's going to have a big that has an impact certainly on the health outcome side of things, and perhaps also on the spending side of things as well. So I think we need to acknowledge that public health investments. I mean, if you think about clean water, vaccinations, public health interventions have tremendous, also tremendous economic impacts and also spending impacts on healthcare. So somewhere we do need to incorporate the level of investment in public health in different communities, especially we start going into geographies and so forth. And California is a very diverse state in many ways, not just geographically or racial, ethnically, or whatever else, even, and that may play a factor in what happened in spending. And some of that also is that people's sort of investments or communities' investments in public health. So whether it's like lead screening or STIs, chronic disease management in the community, environmental things. We talk about social determinants. So somewhere we need to incorporate, and I agree also with Rick that at least I'd start with local and state health departments, right? I mean, you got to start someplace, right? We're not going to capture all of healthcare spending, even what we're doing here. We can start there. They're public entities. They have public budgets. So it's not going to be perfect, but we could probably do some sensitivity analyses and so forth and look at to what degree do different communities, and we know there's variation as someone who's looked at it, in investment in public health and by different counties in the different regions of the state.
Thanks, Richard. Sandra Hernandez is a former public health director in an important county. Certainly appreciate your comments on this and the other issues you want to raise.
It won't surprise anybody. I think that I sort of will pile on a bit to the sentiment. There are certainly many functions that counties do that very much relate to health outcomes and health equity, frankly. And in fact, some of the indicators that our sister organizations are working on, vaccination rates, immunization rates, are fundamentally done by counties. But also just to name that we, as a state, have also carved out behavioral health to counties. And so in spite of the fact that counties themselves may not be reporting entities, we won't get to any realization of behavioral health costs if we also don't look at county spend. So I might just make as a suggestion, and I appreciate everything you laid out, Michelle, like where do you circle it? It might be worth getting a few counties, rural and urban, together in a small group and just sort of say, what are the things we would want to look at in this public health realm? Again, you could could be a big fence or it could be fairly narrow. But as a way to really try to make sure we get at health equity and recognize that we have, in fact, given over behavioral health largely to counties, certainly for the seriously mentally ill. And so if we just look at payers, we will miss a big part of at least that part of the delivery system, which we certainly don't want to do. So we'll have to figure out how we get around the counties not reporting as a reporting entity to get at global spend. And I think maybe doing a little homework with a few counties, some big ones, and maybe some smaller ones, just to get a flavor for how we encircle what we want to put into the global spend.
Okay, I want to wrap us up here. There's so much more to say, and not to be the chair with the final word, but I think about two things in this space. One, when I look at where we're pushing with CalAIM and even our model contracts for Medi-Cal with our plans, we're actually asking them to create networks that go way beyond, clinicians, right? Soon, if we have it our way, in a few years, each plan is going to be talking about their network on social drivers, right? Who's doing homeless service provision? Who's thinking about meals? Who's thinking about the conditions that go beyond public health? Every health plan that's a Medicaid health plan is going to have a really strong relationship with both the behavioral health department, the social services department, and the public health department. Sadly, not every county has it all together. So we do need to look at the different models out there. Then the second conversation, and many of you, at least 4 of you in this collection of esteemed board members know that what we dealt with on the Healthy California for All Commission, we had a meeting where we invited folks to talk about public health and behavioral health. Same meeting, we did half and half on each about how important it is. And then later, the LTSS piece. And the final report really addressed these 3 issues, not with definitive answers on how to think of it all, but that you do think of it and need to incorporate it early, I think was a must. So to me, the coalescence is not whether we should do what we're talking about, but really supporting the team on how to do it and how to do it in a way that we don't lose, and I'm not even going to call it our primary function, because these things, you can't have that primary function without what we're talking about, but how do we do the work in parallel, moving forward with the really important timeline as set by, I think, the hopes and dreams of lots of other people, but not losing the spirit of the things we talked about today in that mix. So I know we can have more conversation on how to do that, bring it back to the board, invite some folks to help us think about it as well. And just like our advisory group, we may need to dig in a little bit more at a different frequency if need be to make sure we don't lose, give the staff the support and direction on this as well. So with that, I think it's safe to move to, did I miss anything else, Elizabeth? Okay, we are going to move to public comment. No, there's a couple of comments in the room, committed, Karen, still to virtual.
Absolutely,
the way we're
yes.
going to do
Thank
it?
you very much.
So Beth Capel, you're first up. Please take it away.
Beth Capel, Health Access. I'd like to start by saying this is exactly the kind of conversation we hope to hear from the board members that we know on this board, which happily is all of you. But I would encourage you all to speak closer to your mic so other people, so I can hear. If I'm having trouble hearing it in the room, I suspect those who are remote are having even more trouble. In addition to the quality and equity discussion that just occurred, I want to thank Director Landsberg for starting with consumer affordability and recognize that nowhere in the work plan does it speak to consumer affordability and tracking that. And that alongside quality and equity, consumer affordability measures should be tracked alongside. That's the point of this exercise. And encourage that at some point within the foreseeable future, and I won't say which board meeting I think it should be at, that this board should return to a discussion of consumer affordability measures, as well as the discussion of quality and equity measures. We served on the Health Access served on the DMHC Equity and Quality Committee, and we're well aware of the work at Covered California and CalPERS and Medi-Cal. And so I think you have a rich trove of information to draw from those sources, as you do a rich trove of California specific data sources, so many of them from CHCF. The final thing we'll say is that that we are struck in looking at the work of this committee that how regressive employer coverage is, and that anyone who is a full-time minimum wage worker in this state is above the Medi-Cal income threshold. So we are talking about the regressivity of employer coverage and the unaffordability of Covered California coverage as we talk about much of this work. Thank you.
Thank you. To the phones.
Noting no hands at this time.
Okay, back to the room.
My name is Dr. William Bronston. I was the medical director for 2 state departments in California for 25 years. 2 minutes, I'm going to have to just give you ice picks. Number one, I would like to urge all of you to attend a showing tomorrow at 7 p.m. There's a flyer on the table over there of a new movie called American Hospitals. It's going to be at the Tower Theater, and I urge you to come. It's going to be quite remarkable. The object for all of this should be looking at health, not health care, and health standards, not healthcare strategies. There's a new book called Inequality, Killing Us All by a fellow by the name of Stephen Bezruchka, who is a public health physician in Washington State. Secondly, I believe that the workforce is grossly too small and culturally insensitive in large part. And the way to solve that problem is to provide global budgeting for all post-secondary healthcare training in the state and to build an entirely new, culturally competent and mass workforce in healthcare delivery. Thirdly, all of this major idea is built into a website that I've created with 40 peers from around the country called ourhealth.pub, www.ourhealth.pub, that deals with every conceivable issue that has to do with climate, that has to do with workforce, that has to do with dealing with the unfunded workers that are out there in the millions, and the savings, as you know, will be in the billions. The next thing I want to mention is that we are under an enormous assault by the privatization campaign that's going on, the shift from Medicare, traditional Medicare, to Medicare Advantage and ACO REACH. That must be opposed fiercely. And finally, we need to buy out and negotiate all health debt at the front end. We can afford to eliminate all existing health debt, and we should be looking at that as an objective and remove that health debt completely from now on in our system. So thank you for your time and your effort. I'm going to try and come as often as I can. I hope I can get on the advisory committee depending upon what Vishal decides. And thank you very much.
Thank you. Rest assured, Vishal will have partners in deciding. Yes. Thank you.
I think that the public health system should be the dominant administrative force in the California healthcare delivery system. Public health should be at the administrative helm of everything we do and everything we think. It is really the source of where the wisdom and the compassion lives.
Do we have any virtual public commenters?
No hands noted.
Okay. Failing as chair, I'm already 15 minutes behind. That's okay. I think we're turning it to you, Vishal, and Michael Bailitt's going to join us.
This is so I'll be covering item 5, state presentations. So I have the privilege of introducing our 2 guest speakers. I've personally spent time with each of them, and these conversations have helped strengthen the implementation of OCA. I will first introduce David Seltz, the Executive Director of the Massachusetts Health Policy Commission, an agency charged with bending the healthcare cost curve and providing data-driven policy recommendations regarding healthcare delivery and payment system reform. Prior to leading the HPC, David was a special advisor on healthcare for Massachusetts Governor Deval Patrick and Senate President Therese Murray. Through these roles, he advised on Massachusetts' historic healthcare reform legislation in 2006, which was a forerunner to the Federal Affordable Care Act of 2010. He later advised on cost containment legislation that established the Massachusetts Health Policy Commission. David, I'll now turn it over to you.
Thank you, and good morning, everyone. Thank you, Elizabeth. Thank you, Vishal. Thank you, Mr. Secretary. And through you to the members of this esteemed board. It really is an honor to be able to present and share some thoughts with you. I think this is your second meeting, so that's just really wonderful. And I just want to say at the outset that I have been following the legislative process closely in California over the years. I had the great privilege and opportunity to testify in Sacramento a few different times as this bill was being discussed over the years. And I just really want to commend the California legislature and the governor for getting this bill signed and established. It is really inspiring to see this bill and to see this effort and to see how you have evolved and adapted some of the things that we've been doing in Massachusetts to California. You have a lot on your plate, as I was just seeing your action plan, but I do want to just say at the outset that this work is incredibly important and will provide a tremendous benefit to all Californians. So thank you for your service. I will put a little disclaimer at the top of my presentation, which is to say, reflecting a comment earlier, how we approached some of these same questions is, I hope, instructive for your conversations, but by no means determinative. We are humble here in Massachusetts about that this is an evolving model, that this is a model that, and an opportunity to learn from other states. And so I will share, some of how we have made our decisions, and in our case, our enabling statute, which was negotiated almost 10 years ago now, or more than 10 years ago, has not really been amended since that time. And so we have been making recommendations and have been working with our state legislature to go back in and amend our enabling statute in many ways to reflect some of the nuanced thinking that is in the California law. So for my quick presentation, and Mr. Secretary, I'll try to get us back on track in terms of your timeline for today. I do want to spend just a minute about the role of the HPC in our history, some of our results over the past 10 years, and speak a little bit about where we are making those recommendations to adapt and evolve our approach and open it up for discussion. So on this first slide is really just the call to action. This is the motivation for why addressing and moderating the growth in healthcare spending is so important. When healthcare spending grows faster than everything else, it just means less and less resources for government, for businesses, and for families and individuals. And this is just one example of that, showing the increase over 20 years in employee premiums, family premiums, employer premiums, compared to other metrics such as personal income increases and general price inflation. This has meant less affordable care for the residents of Massachusetts, and this is a trend that is quite universal. And so when faced with this reality, policymakers here in 2012 passed landmark legislation, you can see on the next slide, really trying to tackle this cost spending growth challenge. And so in this law, Massachusetts did become the first state to set a statewide target for reducing the growth in healthcare spending. It also established a brand new state agency, the Health Policy Commission, which was charged with oversight of this effort and to provide the data and information to policymakers and to the market necessary to work to achieve that goal. I will state at the outset, and I'll probably state it again, it is a goal, it is a target, it is not a cap. It is meant as a measurable target to motivate collective action across public and private actors. I want to spend a minute just on this last bucket on the right-hand side of the slide, because I do think it is important to some of the conversation that you were just having. This is our vision statement at the Health Policy Commission. A transparent, equitable, and innovative healthcare system that is accountable for producing better health and better care at a lower cost. These words were all very intentionally chosen. The addition of the word equitable and for all people of the Commonwealth was intended to embed in our vision the principles of health equity. And in talking about better health and better care, wanted to recognize another principle, which is that our goal is not to decrease spending at the expense of other values, that we think that we can actually moderate growth over time and increase and improve the health of our people. And that should be what we are working towards. So it could be very easy to, if you wanted to just cut healthcare spending, there's ways to do that that would be detrimental to those other goals. And so we really try to keep these principles embedded within our vision to guide our work. On the next slide, we'll just spend a minute about our healthcare cost growth benchmark. And it's similar to the California law. We are measuring total healthcare expenditures. So this is the total sum of both public and private spending in healthcare, as well as the administrative cost of private health insurance, and as well as what patients are paying in form of copays and deductibles and other cost sharing. Again, this all-in approach is really to try to avoid that bubble effect or the whack-a-mole effect, where if we're not measuring something, how can we improve it? How can we track what the dynamics and interplay between these different categories may be? And so it's important for a beginning principle that we measure as much of the pie as we possibly can. Different than your legislation and enabling statute, our law directs the state to establish a single statewide target for the healthcare cost growth benchmark. And that target was established in law, tied to a measure of the state's economic growth or potential gross state product. And so it was set in law at that equal to that amount for the first 5 years, which resulted in a benchmark of 3.6%. The law then allowed for that benchmark to come slightly underneath that economic growth rate. And so for the next 5 years, it was 3.1%. And now we're in a place with our statute where the Health Policy Commission Board has full discretion about where to set that benchmark relative to the economic growth rate. And for the past 2 years, we have set it just at that economic growth rate, not plus or minus. So it's been back at 3.6%. The benchmark itself does not trigger enforcement action. What it does, though, is individual providers and health plans are basically referred to the Health Policy Commission for review if their spending exceeds that statewide target. And if the HPC board so determines that there is excessive spending that needs to be addressed, that we can require the entity, provider, or health plan to implement a performance improvement plan to bring their spending growth back in line with the benchmark. I want to just spend a second on this because I think it's important to maybe notice the differences in these two approaches. Here, where we have this kind of blanket statewide target number, and anyone that's above gets kind of referred for further review. It's in that further review that the HPC looks at things like market size, population served, the quality of care that they're providing, the important access that they may play for certain populations, their price point, their efficiency. All of those factors are things that the HPC does this pretty deep multifactorial review of the entities whose spending was above the benchmark in determining whether a performance improvement plan truly is warranted. So it's really at that stage where we bring in kind of the aspects of equity and quality in kind of determining whether enforcement is warranted. And we have the ability to differentially judge different entities. I think, interestingly, from your conversation, is thinking about how you may embed some of those same principles kind of upfront in the target setting. And I think that's a really interesting kind of evolution of this model. On the next slide, just a little bit about our structure. The HPC is overseen by a board of commissioners. It's an 11-member board. Those board members are appointed by 3 constitutionally elected officers, governor, attorney general, and the state auditor. And you can see on this slide, each member in law has a specific kind of area of expertise that they bring to the work of the HPC. This is, by the most part, a citizen board. We do have the Secretary of Administration and Finance and the Secretary of Health and Human Services that sit on the board, but the other 9 members are citizens of Massachusetts who have expertise in these areas and have been committed to serving on the board. I report to that board, and we are an independent agency. So ultimately, I don't report up to the governor. I report to this board, and the board members all have staggered terms, such that the board would not turn over, kind of after a statewide election. I oversee the day-to-day operations of the agency, and then also I liaise with an advisory council. I know that's a topic for you today too. So the law allowed for the executive director to appoint an advisory council, and that was one of really the first things that I did when I got this job, because I knew how important it was going to be able to put that group together and to be able to consult with them in order to build the trust and collaboration and partnership that I knew was going to be so necessary for this really hard work. Currently today, we have over 30 members of the advisory council. They serve in 2-year terms, and we meet quarterly or more often as necessary. And the advisory council is made up of heads of all of the different kind of healthcare associations and organizations you might imagine, the Hospital Association, the Health Plan Association, as well as business groups and business leaders, consumer advocates, bio and pharma tech, experts in health equity, experts in public health, experts in social determinants of health and data collection. So a quite diverse group of leaders in this state who are committed to working with us on our mission. On the next slide, this is data it is a little bit old. We did this a few years ago. But just to try to highlight for you that small gains in moderating the spending growth can lead to incredible benefits for the residents of your state. And so here we just did kind of a thought exercise and said, if healthcare spending in Massachusetts grew 2.5% annually over the course of 6 years versus a 4%, what would that result in? Billions less spent in healthcare, 10% lower premiums for all families in Massachusetts, close to $9,000 more in take-home pay per worker, and thousands saved in out-of-pocket spending, all leading to less care avoided and fewer financial harms. This is why this work is so important. And on the next slide, you'll see that many other states have now taken up this idea of setting measurable goals to be able to moderate spending growth. And so while we were the first, we are no longer alone, and there are now, with California, 8 states that have established some type of target. It's called different things in different states. And there are a few more states that are actively considering legislation in this calendar year. So on the next slide, just to spend a minute to talk about how the HPC actually does its work and tries to influence the healthcare market to meet these targets. We play a number of different roles. One is as a researcher and reporter, bringing data, issuing reports that provide insights into healthcare cost drivers and spending drivers. We're a partner. We've provided over $100 million in grants, mainly to community hospitals, but also to other community-based organizations that are working on new and innovative ways of delivering care. And much of our effort in recent years has been on addressing health-related social needs and moving healthcare upstream and making those connections between healthcare and public health. We're a convener, so we just bring people together sometimes and bring experts. We just held a special event 2 weeks ago about the healthcare workforce in Massachusetts and its challenges, and had many hundreds of people participate in viewing that event. And then we also act as a market monitor in terms of acting on behalf of the residents of the state who struggle to afford healthcare, to examine the business of healthcare in Massachusetts and how that is changing, and to call out publicly when that market behavior is leading to outcomes that are inconsistent with our other goals of affordability, quality, equity, and access. So on the next three slides, just to share a little bit about some of our results from the last close to 10 years. So on the next slide, this is our performance against the healthcare cost growth benchmark. And just to orient everyone to this slide, the blue dots indicate an annual measurement of what our actual spending growth was for each of those years. The orange dotted line turning into the solid orange line is where the healthcare cost growth benchmark was set, that target. And you can see right away that there are definitely years where we went above the benchmark, and there are years that we went below the benchmark. But overall, when you average out all of these dots, you get to something close to 3.52% average annual growth. And our initial target was 3.6% growth. I think it's important. One of the things that we think about a lot is not just understanding, did we go above the benchmark or did we go below the benchmark? The more important and more interesting question to me is why? Why or why not? And so this really is just the first step in our data and research work. First, we evaluate ourselves to that statewide target, but then we go underneath all of those averages and really decompose all of these spending trends by different categories of services, by geography, by different insurance markets, down to the granular, utilization and prices and provider mix, all trying to understand what are all of the dynamics contributing to healthcare spending so that we can understand, there may be years where we go above the benchmark that we think that's fine because it was actually providing value to the state. And I'll give an example. In one of our earlier years where we did exceed the benchmark was due to a policy decision where we, as a state, extended kind of coverage for a whole population of kind of connector or exchange eligible members. And that contributed to higher spending, but it was based on our principle that we wanted to have universal coverage. And then we felt that it was more important to prioritize making sure that people had continuous access to health coverage than to what that might cost in terms of the benchmark. So that's just an example of the importance of diving below these averages to understand the underlying dynamics. But I'll show you a couple more of the big picture averages. On the next slide is the same metric. Now, this is total healthcare spending growth in Massachusetts compared to the United States. So Massachusetts in orange, United States in blue. And you can see that for the first decade of the century, Massachusetts tended to grow much faster than the United States. That has now moderated, and you can see really from about 2000 onwards that we have been below the US rate nearly every single year. On the next slide is the same type of graph, but here we're just focusing on commercial spending. So the previous graph included Medicare, Medicaid. Here now we're just focusing on the commercial spending. And you can see a similar trend, but perhaps even more stark, that in the late 2000s, our growth was much higher than the United States and then has been below the United States comparable rate pretty much every year since. And if you compare since 2012, that blue line to the orange line, and you kind of calculate the delta, it's close to $10 billion in terms of lower spending in Massachusetts compared to if we had been growing at the US rate. On the next slide, another important part, as I mentioned, of our work is around market monitoring. And Vishal talked a little bit in your plan about filling out the CMIR, the cost and market impact work. And so I just want to speak to that for just a minute or two. So on the next slide is really the case here. We know that the business of healthcare absolutely impacts system performance, medical spending, access, and quality, and that there have been rapid consolidations and new alignments between provider organizations. And so as part of our law, providers are now required to provide notice to us when they engage in these types of material changes to their operations. And the HPC can elect to conduct a more fulsome, comprehensive review of those transactions, which we call a cost and market impact review. Ultimately, our agency is not empowered to block a transaction. We are not empowered to impose conditions on a transaction. Our role really is to provide transparency and accountability in a very data rigorous way in examining kind of the comprehensive potential impacts of these changes to the market. But they are used by the other enforcement agencies that we partner with in terms of the Attorney General's office and the Department of Public Health. And I think, motivating this as a reflection that antitrust, while important, may not be sufficient to be able to, meet the kind of rapidly evolving market and the way in which that those market changes can have impacts that go beyond just competition. So on the next slide, we can share with you here some of the questions that we ask when we are doing these comprehensive reviews. We want to hear what were the priorities of the parties in proposing a consolidation or a new partnership. What are the potential impacts going to be on the pricing and the spending of those organizations? How do patient care patterns, how will they change? How will the clinical quality change? And what is their relative performance? How does the transaction impact access to needed care for patients in different party service areas? We've also asked questions about, what is this organization's role in serving public payer patients? What is this organization's role in serving non-white patient populations? And so as part of these reviews, we go much further than just your standard, is this a market competition problem, but really try to think about impacts that go into access, quality, and equity. And the result of these reports and these reviews, I believe, has been a very positive, even if we haven't had that full authority to block or to require conditions. And on the next slide, just to show you some of those positive impacts. One, just tracking and making this stuff transparent allows for future accountability. So we have had entities who've disclosed plans for a transaction that we have not thought needed a full cost and market impact review, but nonetheless, we can go back to those, those transaction plans, into the future and say, did they actually achieve what they set out to do? Were there unintended negative impacts or positive impacts? And in going through our reviews, we've been able to have entities make voluntary commitments, such as increasing access for Medicaid patients when we've identified certain providers as, serving a disproportionately low patient panel. And as I said, our reports have also been used by the other enforcement agencies and have been instrumental in helping them think through what conditions or what impacts may need to be addressed. And finally, in some cases, our review and our reports have led to the abandonment of plans to merge or to consolidate by the market entities themselves. There was a case early in the HPC's career where there was a consent agreement for a pretty significant transaction to move forward that went before judicial review. And the judge ultimately did not sign off on the consent agreement and cited the HPC's report as the most compelling piece of evidence in her decision. So finally, on the next slide, just wanted to share a little bit about what's next for us. And here, laying out some of our big priorities for this calendar year, 2023, continuing to bolster our cost containment activities, really engaging in a conversation in our community about the workforce challenges and solutions, embedding equity in every single thing that we do, further enhancing our prescription drug transparency, and also see an opportunity to reduce unnecessary administrative waste, especially at a time of strained resources. And we are also working on the next slide with our legislature to amend and evolve our enabling statute to get at some of these things. So first, around having a more nuanced approach about setting the benchmark, and perhaps thinking of moving away from just a statewide benchmark to something that would could include other metrics based on market size, quality, provider pricing, some of the things that you all are considering. Pricing, provider pricing, and pharmaceutical pricing continue to be the overall driver of healthcare spending. We think there are new opportunities to expand the state's enforcement and oversight of that driver. And then finally, we would need to make sure that as we're focusing on the provider pricing and the provider market, that whatever savings are generated are truly being passed on to our consumers and our businesses in the form of lower premiums, lower cost sharing, and that we are actually driving affordability through all of these efforts and holding the health plans accountable to advancing affordability. So that was my presentation. I know I moved quickly, but I just want to again offer my hand in partnership and continued dialogue and conversation as you continue your work. I have already been in touch with Elizabeth and Vishal many times, but for all the members of the board and the secretary, if there's at any point I could be helpful, please do not hesitate to reach out. And I'll stop there.
David, thank you so much. Very instructive. I think the board probably has questions. I'm going to ask Vishal to introduce. David, if you can stick around, we're going to have our Oregon colleague present next, and then we'll open it up for collective conversation from the board and then the public, and then adjourn for lunch.
So next up, we have Sarah Bartleman, manager for the Oregon Health Authority's Cost Growth Target and Healthcare Market Oversight Program. Sarah has worked in Oregon state government for almost 15 years, including previously leading Oregon's Medicaid Incentive Measurement Program. She has also consulted on analytics and evaluation projects with partners across the West Coast and worked on chronic disease prevention programs in Oregon, Massachusetts, and California. Sarah, please take it away.
Thank you so much for having me. I specifically requested to present after David. We've done this a couple times before, and I get to start my presentation by saying everything David said. So thank you again, David, as always. Great to co-present. And I really love how you provide such a fantastic framework for why we're doing this work, the affordability challenges that are facing people, as well as the growing momentum across the country for states adopting this program and this work. So David has covered a lot of the things that I normally say in my cost growth target intro presentations. So I'm going to focus today on just a couple of things where maybe the Oregon model is a little different, or where our work might be particularly relevant to California's upcoming considerations. So I'm going to talk about our legislative path and how our program was structured. I'm going to talk about some key program design differences in a couple of areas, and then I'm going to talk a little bit about our governance structure. So you have seen this slide already. We were the 4th state to establish a cost growth target program. And if you can go to the next slide, I will talk about how we got there. So we had been working on this for actually a really long time. In 2017, we had a legislative task force that was charged with looking at how to address healthcare costs. And their specific charge was to consider a hospital rate setting model. So originally looking at Maryland and looking very specifically at hospital costs, hospital prices. That legislative task force pretty quickly realized that that would not be sufficient, leading to that sort of squeeze the balloon kind of problem, whack-a-mole problem, where we didn't want to just focus on healthcare costs or hospital costs. So that task force branched out and looked at other models, including what was happening in Massachusetts with the cost growth benchmark program. The legislative task force ultimately recommended that a cost growth target model would be the best fit for Oregon, and that's what we should pursue. That recommendation led to our establishing legislation in 2019 that created our cost growth target program, established the authorities within the Oregon Health Authority, and stood up our implementation committee. Our implementation committee was charged with setting the parameters, the recommendations for the program, many of the design decisions that you all will be considering. I think just listening to what's on your work plan, I was having flashbacks to 2020 and some of the questions and considerations you'll be weighing. So our implementation committee worked for 2 years in developing those recommendations and standing up a lot of those decisions. So which payers and providers were included, which costs are we measuring, what does it mean to be accountable for cost growth in Oregon, et cetera. And then we had a second piece of legislation in 2021, and this was a deliberate staggering that our legislature had envisioned. So in 2019, when we stood up the program, we were looking to Massachusetts as the leading state, the only state with this. And Massachusetts has, as David mentioned, performance improvement plans as a mechanism. And the Oregon legislature and our stakeholders were concerned that if we only had one tool for accountability, that we would be afraid to use it. And so they wanted our implementation committee to consider multiple tools for accountability and come back with a recommendation of multiple strategies and approaches. So we had subsequent legislation that gave us our authority for accountability, and I'll talk about what those are in a minute. So this is our legislative path. There's a whole bunch of other details that have happened with our committees and our work groups and our administrative rulemaking to stand up the program, but this is our developmental history. Next slide. So jumping around a little bit, a couple of elements of our cost growth target program. One piece that I really want to call out specifically for California and that I've been talking to Vishal and the staff about are who are we talking about? So this is a decision consideration you'll be making. Our establishing legislation says that Oregon's cost growth target must apply to all payers and providers in the state. And this caused some consternation. Are we talking about an individual doctor, an individual practitioner? Is that a one doc shop versus an individual provider within a larger health system? So our implementation committee had a lot of conversation about how to define this. And we had a lot of, is the juice worth the squeeze kind of conversations. Oregon has a really robust domestic insurance market. We have a lot of health plans that operate in Oregon. There's sort of a long tail of payers with very few covered lives. And so we had a lot of discussion about who should be included and where should we draw that cut point. So we ultimately landed on payers that have at least 1,000 covered lives in Oregon. Currently, that's about 29 payers, and you can see the split of how those are divided up across the various markets, Medicaid, Medicare, and commercial. For provider organizations, we ended up on a model where we're rolling up to a parent organization, so not individual clinics, but the overall health system, and that have at least 10,000 unique attributed patients. So we have about 51 provider organizations in Oregon that meet that threshold currently. We check this every year because the market changes. And I want to note that we have a couple of shared payers and providers. So Providence St. Joseph is a major payer and provider in the Oregon market, also in California. Adventist Health is another large system that we both share, as well as with emerging and continued market consolidation. I think we're continuing to see some of that cross-state collaboration. So we know that there's a lot of interest in how our programs are set up and that we will be looking to hold the same entities potentially accountable for cost growth in the future. Okay, next slide. I'll talk about our components of the program that are related to accountability. So as I said, our charge was to not just have performance improvement plans. We needed to have something else. So over the course of our implementation committee's deliberations, we landed on a sort of threefold model. The first is public transparency. So that's the naming and shaming aspect. So public reporting, identified reporting of payer and provider performance, as well as what those key cost drivers are. And annual public hearings where we'll have those conversations publicly and have the opportunity to maybe put folks on the spot or to have them come explain what's been happening within their part of the health system. We have performance improvement plans, and our performance improvement plans are structured a little bit differently than Massachusetts. They're a little bit more, I want to say, automatically triggered. So because they're sort of in the middle of our accountability spectrum, they're not sort of a last resort. David, not to put words in your mouth, but I think the intention for Oregon is that many organizations may be put on a performance improvement plan, and that's not necessarily a bad thing. That performance improvement plans are an opportunity for shared accountability, for shared coming together and trying to solve these problems, maybe directing resources where needed, and not intended as a big punishment. Then what we've added, and I believe is also similar to what California will be considering, is the opportunity to impose financial penalties on organizations who, we have a couple of phrases here, sort of repeat offenders or who egregiously exceed the cost growth target for multiple years. And we will be looking at a 5-year period. And so for organizations who continue to exceed the cost growth target without good reason in 3 out of those 5 years, we will be assessing financial penalties. And of course, underpinning all of that are ongoing conversations with all of the entities, both behind closed doors and publicly, to understand the cost growth drivers and those reasons for exceeding cost growth. I think, as we've all said, and part of the shared value in all of this work is that not all cost growth is bad. We have areas of historic underinvestment. We have things like primary care and behavioral health spending targets. We have specific investments from the legislature or the federal government where we know we are trying to increase spending, and we want to see that happening. And we don't want this model and this program to be penalizing anyone who is working on that. We have a specific call out for investments in social determinants of health and investments to improve health equity as part of our model and as part of good reasons for healthcare cost growth. On the next slide, you can see our current list of good reasons. So we have some explicit built-in flexibility so that there are factors that drive healthcare costs that are outside of a payer or provider's organization's control. And if through those conversations to understand cost growth drivers, we can agree that this is why an entity exceeded the target, they would not be subject to performance improvement plans or potentially financial penalties. So these include things like changes to state law, particularly changes in mandated benefits. This has been a really hot topic for us this legislative session, as Oregon's happy to mandate insurance coverage. And so as additional benefits are added or requirements are made of payers, those do increase costs, and we recognize that. And so, for example, in the 23 legislative session, Oregon is considering proton therapy as well as IVF, both of which are pretty expensive mandated benefits across the board. Also looking at new pharmaceuticals or new treatments that are entering the market, pharmacy costs are absolutely a big driver that we all share as a concern, and we wouldn't necessarily penalize an organization if it was because of a new drug entering the market that they were providing to their members or to their patients. We've added an acts of God placeholder, and that's in quotes because that's sort of the insurance terminology for disasters and other unexpected, unforeseen circumstances, including COVID. We all know that COVID-19 has changed healthcare costs, and because we are measuring across that time period, there are a lot of things going on that we don't necessarily want to penalize folks for. For example, we know that a lot of our payers provided additional dollars and support payments to provider organizations in the first part of the pandemic to help them keep their doors open. And we don't want anybody to be penalized as a result of those support dollars. Okay, and then macroeconomic factors, sort of a hot topic with changes in inflation, workforce costs, labor costs going up. That is also something that we want to make sure that we're keeping a close eye on and not inadvertently penalizing anybody. Okay. Last bit about our program, we have a really long on-ramp, and this is deliberate. This timeline was set up in 2020 with our implementation committee, and we have a couple of staggered pieces of the rollout. So in 21, we launched a technical advisory group to work on the data submission, data validation methodologies. We began data collection. In 2022, we had a first public hearing that was focusing on impacts of cost to consumers and the affordability, sort of the why we're doing this. We began to engage with those 51 provider organizations because some of them did not know that this program was coming, and we needed to do a lot of groundwork with them to say, here's what this program is and what it means for you. This year, actually, over the next 2 weeks, we will be rolling out our public reporting that includes identified payer and provider level performance for the first time. So we've been doing a lot of behind the scenes work with the payers and providers to share data, validate data, make sure they understand what's coming before that public reporting happens. We do not start performance improvement plans. Nobody would be subject to a performance improvement plan based on their cost growth until 2025 at the earliest. And that is a 1-year delay from our original staggered timeline because of sort of the macroeconomic factors and concerns about what's coming out of the pandemic. And then financial penalties currently would not begin until 2027. There has been some proposed legislation this session that would modify this timeline and extend it even further. But a lot of this, we had some really deliberate decisions and discussion with our implementation committee about the importance of providing this on-ramp. This is a very large and complicated system, and it takes time to make those changes. Contracts are negotiated over multi-year periods, and payers and providers need to know what the target is so that they can negotiate that and bake maybe the target into those agreements, and then we'll measure that later on down the road. Understanding that some of these larger scale initiatives might take time, and so not penalizing anyone immediately and making sure there was time to make changes was really important. Okay, and then finally, I think last couple things I want to say, one more slide. I want to talk about our governance structure. So Oregon has the Oregon Health Policy Board. This is a legislatively created board. They provide direction to the Oregon Health Authority broadly. They oversee a lot of our healthcare transformation, health system transformation efforts, including value-based payment, Medicaid transformation, workforce, all kinds of things. Cost growth target work is one of their priority areas. Our cost growth target committee was put under the policy board and reports up. So I think direct comparison to you, our implementation committee had many of the conversations you will be having, but reporting up to the policy board on sort of an informational basis. We also created underneath our implementation committee a technical advisory group, and that is not an appointed member group. That is just an open meeting, public meeting that payers and providers can come to and talk about some of the detailed methodology. So how are we measuring with statistical certainty? How are we collecting the data? Can we break out medical and retail pharmacy separately? So a lot of really in the weeds discussions with the payers and providers happen there. Our implementation committee legislatively sunset in December of 2021. One of their final recommendations was that this work needs an ongoing governance body. So in 2022, we stood up an advisory committee. So name change, but similar role. And that group was seated earlier this year and continues to provide direction and decision-making for the program, including revisiting the target value. They were the ones who agreed to extend that performance improvement plan timeline by 1 year. And then the last thing here is we recently spun off a work group of advisory committee members who really want some dedicated space and have really drawn attention to what does it mean to have equity embedded in this work? What does it mean to think about cost containment and equity together? And we are going to be coming back with some recommendations and possibly some frameworks for broader adoption in the fall. So really thinking about the intersection of these areas of work. And I would say that our conversations have been, our work group members are really interested in pushing this beyond sort of stratify your data. That's a great first step. And they say, great, and then what else? That cannot be all we do. So I think I'm really interested in seeing where this conversation goes. And this is very alive for us right now. Okay, and then go one more slide, one more. The last thing I want to say, one more slide, please, is our advisory committee membership. And this is the result of some work that our policy board has done to really focus on committee diversification, representation, recruitment, and retention. This is an ongoing body of work across all of their committees. We had the opportunity to deliberately stand up our advisory committee, and we did that really carefully. So we balanced membership across 3 different domains. So sector, demographics, and expertise. And the sector part is the part I want to talk to you about today because we have a 50-50 split between healthcare industry representatives and non-healthcare industry representatives. And this was on purpose, wanted to have a really strong consumer advocate purchaser perspective. And we thought it was really important for buy-in that payers and providers who are subject to this program are part of the advisory committee. They do get to make decisions. They do get to be part of that. One thing that we have very specifically carved out of the advisory committee's responsibilities is determination about whether or not anyone should be held accountable. So that will be an agency level decision, not an advisory committee decision, because we didn't want to introduce any conflict of interest where a payer or a provider who is subject to the program then gets to decide if they should be held accountable. But I think with that sort of conflict of interest worked out, we're really happy to have high level executive leadership representation from across the health system and providing their perspectives on this program and continuing to demonstrate their support or raise concerns about things that we need to be taking into consideration. And I think it's really just based on the first couple of meetings we've had, really strengthened the work. And I will stop there. And as David said, as always, Oregon is also really happy to help. We're so excited about California coming on. I personally am really excited about some of the nerdy parts of your program and how you will be adapting and continuing to evolve the model, particularly the regional and the custom benchmarks for different parts of the sector and the state. And I think there's a lot that we will learn from your emerging work. So thank you for having me and looking forward to our continued work together.
Terrific, Sarah. Thank you so much. And both, I think, on behalf of the board, really impressive work, different timelines, different stories, histories, even slightly fine-tuned objectives along the way, but really amazing to hear both the great work you're doing now and the history of getting us all to where we are. So we'll open it up to the board for questions now. Public will have time for some public comment here. I hope David and Sarah can stay and answer some questions along the way, but I also know that you committed to friendship along the way, and if we need you in the future, we can find you. So with that, David Carlisle, we'll start with you.
Well, David and Sarah, thank you very much for those great presentations. It's fascinating to hear what's going on in other states, and thank you for your personal leadership and the leadership of Massachusetts and Oregon. I really have two questions for you, kind of the big picture question, but also one that we've talked about earlier this morning. The big picture question is, based on your implementational history and perspective, and the fact that we're now in a trajectory setting mode here in California, do you have kind of takeaways or wish you had done this things that you'd want us to take into consideration at this point in time? And the second question is has to do specifically with public health inclusion in measurement of expenditures within your states. What was your decision making with regard to public health expenditures?
Well, I'm happy to go first. I think in terms of one, one piece that I've just been reflecting on is in our process, the identification of payers or providers that have exceeded the benchmark and the kind of comprehensive review that we do, very similar to what Sarah talked about examining, are there things outside of the entity's control? Are there good things about this spending that may lead us to not want to do a performance improvement plan? All of that in our statute is confidential. And so, and it's a really important process, but in terms of the public, it hinders our ability to really have those conversations, kind of as a community. How do we evaluate? How do we hold accountable? It's incredibly thoughtful from our board, but it is all confidential. So I would think carefully about, what are the appropriate times for confidential protections, and when are the times when it's maybe more important to lean on public transparency as you make some of these design decisions. And you can hear even from Oregon's perspective, they initially, I think, did a year where that's going to be confidential, the list, and then in future years it will be public. So they're approaching it differently. On the second question about public health expenditures, so public health expenditures are not included in terms of our calculation here. And I think some of the same considerations and challenges that Vishal talked about earlier are reflective of our experience as well. That being said, I think the kind of the principled point that we should be looking holistically is absolutely kind of core to our work, and the effort to create connections between if our goal is better health, well, what do we know about like what actually drives health improvements? The health system plays a role, but it plays kind of a, not that big of a role if you look at all the determinants of health. And so I think we have been really on a journey to better incorporate those principles and ideas into our work. And, to the question of like, should we be measuring that? It's interesting. There was an academic report from many years ago that compared kind of social spending and medical spending, between the United States and other countries, and you can kind of see some of these inverse relationships. And I think that's something that we should be kind of doing at a state level as well, as thinking about how much are we spending in the healthcare system versus how much are we spending in public health and other supports, and is that the right balance? And I think that's an important question. But how we incorporate that in the data, I think we were similarly challenged. But I'll have Sarah chime in with any other thoughts.
Yeah, on both questions, I have thoughts. So on the public health piece, similarly, we are not including public health spending writ large as part of our measurement or total healthcare expenditures. However, we have a number of county local public health authorities who operate clinics, and they count as providers, and they receive claims and non-claims based payments. And so those are in that list of 51 providers that I mentioned that are sort of in. That includes 4 or 5 of our large county health departments. So I think there's a difference between sort of the grant funded public health investments, dollars flowing from CDC, or investments in those programs versus public health operated delivery of services, what we might consider the traditional health system. So some of those dollars are in, and I'd want to be careful about that. I also think there's a little bit of a slippery slope. I agree that it's important to reflect, and I'm probably going to go back to my team and talk about this a little bit more too, based on your earlier conversation, but I don't know where you draw the line. Do you only draw the line on chronic disease programs that public health spending? Do you include all CDC dollars and all of the state's public health budget? Do you include environmental public health? Do you include social services, as David was saying? So I think there's some really good decision points there. I personally would want to be really careful about including that as part of total healthcare expenditures, but I think as a complementary supplement, like understanding the ecosystem, it's really important. And then in terms of what we would do differently, I know I did just talk to you about our great staggered timeline and how deliberate it was and how nice it was that we had that time and all the reasons why we did that. Now let me tell you about why that was a problem. Because we have been talking about the cost growth target in Oregon since 2017 and 2019 legislation, we are now facing legislative challenges where folks who don't like the program, who will remain nameless, can come and say, we've had this program for years and it's done nothing. You should get rid of it. And that's been really hard for us to counter. So I think because we've had this deliberate phased in reporting, we haven't been publicly reporting performance, again, coming in 2 weeks. Because we haven't been doing that, I think we've lost a little political capital, and it's made it really easy for folks who oppose the program to say, there's no point in doing this. You've had this program since 2019 and costs have continued to go up. There's no point. And I don't know what my recommendation for you might be, other than just be really careful of that. With the staggered timeline, that's a risk.
I really appreciate that last point. You saw the nodding heads around our table, and especially from our former legislators who've understand that kind of pressure. I would just also add, I really appreciated your point, Sarah, in particular on the public health spend, that some public health investments are truly clinical investments, right? They are, I know I worked on them in 2 counties. Sandra, you did a lot of that. A lot of us have thought about how you do that. David, Carlisle, you run a campus with a whole bunch of public health services that are part of the clinical delivery system. And then the other piece is to the point David was making, we have built in California, in part because it doesn't get covered anywhere else, a lot of those social determinants within the healthcare delivery system. And there's a healthy debate on how far you go on that point. But we are certainly leaning in with our actions on that in a way. And that's going to be captured in some of this spend because it's part of what the health plans are going to be thinking through. So we'll have to figure out how that is at least contextualized and understood as we look at what flows into this. Okay, Elizabeth Mitchell.
Thank you, and thank you for the presentations. So this has clearly been years of, work, effort, political achievements. What has been the measurable effect on affordability from the consumer perspective?
Well, I'll speak to this, and I think this probably goes also into a lesson learned category, which is a recommendation to really center consumer affordability in your conversations and your discussions and deliberations, because that question is a hard one for me to answer, honestly, because I can show you graphs that say, our total healthcare spending was below the U.S. averages, and if we were at the U.S. average rate, it could have been X percent worse. But that's not that's a tough message for when people are avoiding care because they can't afford it. Is that it could have been worse without these efforts, and so we have really tried as we've gone along in this process to include within our kind of dashboard of performance metrics a lot more around affordability, how much percentage of income, how much are people deferring necessary care due to costs, so that we're really kind of keeping track of those different those metrics at the same time that we're looking at kind of total statewide metrics. And we have recommended, to the legislature to actually think of an affordability benchmark, an affordability standard that we could set in law and in statute that could either be monitored by us or could be monitored and implemented through our Division of Insurance. So, when I speak to other states and when I speak about this program, I do try to bring it back to how do people feel healthcare costs? They feel it in their premiums, their copays, and their deductibles. They don't necessarily feel it in total healthcare expenditures, and those two aren't necessarily the same thing. But nonetheless, need to continue to have that focus. So that's how I've been thinking about it. It's not a perfect answer other than to encourage you to be really thinking about that from day one and how you communicate the importance of this work in being able to drive to affordability gains.
Everything David said, especially on the messaging challenge. I do want to add just one piece from Oregon where it's not directly about the consumer affordability, because that's a really hard message. But one place where I think we're seeing success, even before we begin our public identified reporting and accountability mechanisms, we have heard from a number of payers and providers that the cost growth target has showed up at the contract negotiating table. And there have been conversations that say things like, the state has said, I can't give you more money, which is not quite what we said, but close enough. Like the conversation is being influenced in that way. And I want to take that as a success, even if the thread to the consumer is then it could have been worse.
Can I just add one more thing? And just to give a concrete example of, I think, something where we have had a real gain is we required our first performance improvement plan last year. And so this was a big step for the HPC and for our board, who unanimously voted to require a performance improvement plan of our largest integrated health system in Massachusetts, Mass General Brigham, which is anchored by Mass General Hospital and Brigham and Women's Hospital. And through our process, it really is up to that entity to propose their plan to bring their spending back in line. And I'll do a lot of credit to the leadership at MGB, that's the acronym for the health system, who from the top level of the organization said that we want to be part of the solution with the state, that we're going to work with the Health Policy Commission to come up with a great plan. And they, through some back and forth, did come up with a really thoughtful plan to bring almost $200 million out of their spending base in 18 months. And all going to be measured and evaluated publicly by the HPC. And as part of some of their concessions and parts of their plan was actual, price concessions and expanding telehealth, expanding care management programs, expanding some of their Medicaid risk arrangements with the state. Those are, it's hard to draw a direct line between something like that and an individual patient and what they may benefit, but it is certainly a comprehensive plan and one in which we're going to be working closely with them to see how that impacts and can benefit not only their patients, but other patients that use that system.
And sorry, can I make one more point? This is the problem with asking us to come talk. One other thing that I want to count as a success is that we have seen references to the cost growth target and meeting the cost growth target show up in other subsequent legislation. So Oregon recently passed and launched a market oversight program. So similar to the CMIR programs in Massachusetts, similar to what California is standing up, we review proposed transactions between healthcare entities. One of our explicitly directed criteria to look for is the potential impact of the proposed transaction on ability to meet the cost growth target. So there's a sense that it is a foundational piece of policy or a foundational program, and that the data and the cost growth target as a measurement can be used to reinforce other health policy initiatives, whether that's market oversight. We also see this playing out with some of our value-based payment work. And it's also come up as we think about some really interesting possible global budget models, regional purchasing collaboratives, and whether and how the cost growth target factors into that. So it's really been able to be leveraged in these other programs and initiatives.
Okay, thank you. Richard Pan.
Thank you. And again, thank you so much for your presentation. I'm also conscious we're getting a little short on time, but two questions. One is that can you talk about how your processes have involved people with chronic conditions? For example, we know that the sickest 10% spend 2/3 of the healthcare dollar. So, I mean, some census, when you say we're going to crank down on spending, they're the ones who get impacted first. How do we ensure that their voices are heard? So do they have representation so that you have people who are in that 10% sickest group, whether behavioral health, physical health, that they're represented in the discussions? And second of all, I did want to touch a little bit on labor costs. So right here in California, we have a campaign to be sure we have a $25 per hour minimum wage for healthcare workers. We see increasing rates of unionization. I know MGB is having, going on a unionization campaign, organizing campaign for their resident physicians. We see this, and then we know that there's a nursing challenge with drop in the nursing workforce related to COVID, et cetera, other things. So how do you incorporate labor costs into your cost target? So, I mean, workers deserve to be paid.
I can go first on this one, David. So to the question about representation, both on our advisory committee and our implementation committee, we have had consumer representatives. We have not asked people to specifically disclose chronic conditions, although, again, as part of that member diversification, we have been getting more into disability and other lived experience, especially with healthcare costs. I think one interesting thing about this work is that maybe unlike some of our Medicaid work or other state programs, we are all also consumers. Many of us have health insurance. We interact with the healthcare system, and our experiences also factor in. I would say that all of my advisory committee members have a personal experience, even if they don't necessarily, fall into that sickest 10%. So I would say that we had pretty good representation, and we have good representation on that. I think the way that we are addressing that, and this has been from as part of our quality and equity work as well, we have a section of our work that we call monitoring for negative impacts. It was originally called unintended consequences, and then they said, wait, these might be deliberately induced things that people are doing to contain costs, so they are negative impacts. And we are monitoring for that. We want to make sure that we're looking at things like prices rather than utilization or access impacts. We want to look at what strategies the system is implementing. There's a lot of concern about risk adjustment, cherry picking, lemon dropping of patients, and how does our attribution model play into that? So I think I don't know that there's one single answer, but these are all solutions, or not solutions. These are all things that we are keeping an eye on and looking to make sure are not incentivized or inadvertently promoted as the way forward to meet the cost growth target. And one point on labor, same conversation here. I think we are really trying to differentiate workforce costs. I think we hear a lot about workforce costs, labor costs in the health system, and it tends to come across as sort of a single talking point, but it's actually really nuanced. There's minimum wage and wages, livable wage for frontline workers, which we absolutely support and want to see happen. There's executive compensation, which is a really different bucket. And then with the pandemic, we've seen traveling nurse costs, traveling labor costs, or contracted labor costs, and that's an issue. And so I think my goal in these conversations has been to try to differentiate which of these are we talking about. And if we're talking about frontline labor costs, great. Those are things that you need to do to pay people a livable wage, to ensure that they can afford healthcare themselves, and to provide care to people. I think under the Oregon model, that if an organization came to us and said the reason we exceeded the cost growth target was because there was a minimum wage increase for all of our frontline workers, we would say, great, no problem. I think that's not what the data actually look like. I think when you look at it, executive compensation is a much bigger piece of that pie. And so I'm really interested in continuing to find ways to drive some nuance into that conversation and to take a closer look at the data to understand when we say workforce costs are going up, what exactly is happening and who is the problem, so that minimum wage workers, frontline labor are not bearing the brunt of the blame.
Thank you.
Sorry, I'll be quick on this too.
Yeah,
just to reflect, again, bringing different voices into our advisory council, consumer voices, disability advocates, being a public body, being transparent, holding public hearings, really trying to extend the ability for all different stakeholders to be a part of this work has been a priority, similar to Sarah. On the labor, and one last thing I'll say on that is, when we have done evaluations of providers who have exceeded the benchmark in our confidential process, we've actually had providers who said, I had, 6 very complex, high-cost patients, that those alone drove my spending above the benchmark. And we would, of course, say, okay, thank you, and we'll see you next year. We would always want to be thoughtful and reasonable. And I think the same thing applies to labor costs. If entities come to us and said, we exceeded benchmark because we needed more revenue from the health plans to pay these traveling nurses at this particular inflection point of the Omicron wave, we're going to be very reasonable about not imposing punishments or accountabilities or performance improvement plans where it was really outside of their control. And the other thing we've done there is to try to bring our research and data expertise to those conversations. And as I said, we held an event on the healthcare workforce just to bring all of the different interested stakeholders together to say, what are you experiencing? How is this feeling? What could the state writ large do to help organizations? And we were very specific in looking at separating out direct care workers from registered nurses, from behavioral healthcare workers. Those are the 3 areas we focused on in our first report. So I think there's an ability to use our data, use our research, use our public bully pulpit to bring people together to talk about these issues as well.
Great. I'm going to, Sandra, have you be our last board question on this so we can move to public comment and then to lunch.
Sure, I'll be very brief. Thank you both for your leadership in your state and for sharing your knowledge with our team and with us today. Very much appreciated. I'm curious, as you've looked in a deeper analysis at the reporting entities, whether you have seen any shifts of expenditures into primary care or behavioral health. Is that something that you have begun to actually see in your analysis today?
So we just did our first baseline report where we calculated the proportion of the healthcare dollar that's being spent on primary care and on behavioral health care. So we have just done the first year of that, and look forward to, we're going to be doing that every year. And, happy to kind of share data specs with you all as you're thinking about how do you kind of define and measure primary care versus behavioral health care. What we don't have, and another one of our recommendations to our legislature is to let's set targets for improvement. Let's set targets for actually increasing the proportion of the dollar going to primary care and behavioral health care and hold ourselves accountable as a state to that, even underneath the broader statewide benchmark. And I know that that's something that Oregon has thought a lot about as well.
Yeah, we have a primary care spending target in Oregon, and we've been measuring and reporting on that for several years, sort of outside of the cost growth target program. And I can share that data if anyone's interested in seeing it. We are also exploring what it means to have a similar measure for behavioral health spending. I think sharing a lot of specifications with the Massachusetts team, doing some iteration. We are collecting this data, and I think I've seen some really interesting shifts in behavioral health spending sort of between 20, 21 over the pandemic. Telehealth, people accessing behavioral health really changed a lot. That's different. That's more utilization than necessarily, shift of where the dollars are being spent. So I wouldn't say anything conclusive, but absolutely an area of interest, something we intend to continue monitoring, even though we do not have an official state spending target for behavioral health.
Great. I know we could go on for a bit longer. I just want to, last comment. I think, Sarah, your invitation to think about how our shared border kind of matters here and thinking through kind of the shared systems in Oregon and here less so for Massachusetts, of course, but certainly for Oregon and California, I think we've teamed up on things throughout the pandemic that I'm very grateful for your state leadership on, and there may be opportunities here, so worth noting. Okay, moving to public comment, first in the room, then on the phone.
May I ask, friends, are you aware of the mandate in the Affordable Care Act for the triennial comprehensive review of health systems for every single nonprofit hospital in the country? Have you been able to use that? Do you have any notion of the virtue of that, and what are its failures?
Thank you.
I can take a stab. Do you want me to take a stab at that?
No, actually, as we appreciate all of our public comment, we will take them as comments and continue to take the others, both in the room and virtually. Do we have any comments from the public virtually?
Noting no hands raised at this time virtually.
Okay, we'll stay in the room.
Beth Capel, Health Access California. To begin by noting that California has had community benefit reporting since 1996 and have been doing triennial reviews since then. While it could be improved because we've learned a lot since then, that is another of the responsibilities of HCI. Also to note that our law, as Director Landsberg said, improves on other states. We think we are the only state in the nation that looks at the labor force impacts in the way that we do. We are contemplating your responsibility to do. We would also note, and I think this is unusual but not unique, that there is another part of the law that requires the Department of Managed Healthcare and the Department of Insurance to factor in the spending targets into rate review, and that unlike any other state in the nation, and thank you, Dr. Pan, for your help in getting to this point, we have rate review for individual small group and large group products, and 3/4 of our commercial market is subject to that rate review. So there is a feedback loop here that exists in California, and that another part of the Health and Human Services Agency is responsible for. Thank you.
Great. Any other public comment?
Noting no virtual hands either.
Great. So with that, it is just before 12:30. Let's give everyone 30 minutes for lunch, and I will spend 5 of my minutes talking to our team about how we still end on time. Okay, terrific. Thanks all.
I'd like to remind members not to discuss any topics that were brought up at the board today. Thank you.
Welcome back. We have our full board back in the room, and is Ian back on?
We know if Ian's back on.
He is. Okay, so we're going to get back started. Thank you all for coming back promptly. We have 3 more agenda items, 2 with presentations and conversations, and then, as we always do, wrap up with general public comment. So let's move into agenda item 8, which Vishal is going to present, and we'll come back to 7 right afterwards. So Vishal, go ahead, please.
So I'll be reviewing the requirements for.
Oh, before you get in, can I just say, we had a lot of really rich conversation about the advisory committee. This agenda item is narrowly focused on how we're going to get to the advisory committee, not who's on it, how we're going to run it, how frequently it's going to, all the really important things that we heard loud and clear are important. So when you look at this and say, how are we going to do that in 10 minutes? Well, you have to understand what we're trying to do is not the whole conversation. So Vishal, with that, take it away.
So I'll be reviewing the requirements for the advisory committee and presenting potential options for board action. Next slide, please. So the enabling statute requires the board to establish an advisory committee to provide input and recommendations. The board is required to appoint members of the advisory committee by a majority vote of its voting members. As shown here, representation for the advisory committee includes a broad cross-section, including payers, purchasers, providers, consumer advocates, and organized labor. The statute also requires that members have relevant areas of expertise. This includes areas such as healthcare economics, healthcare delivery, primary care and behavioral health, and expertise in enhancing value and affordability. Next slide. So these are just the areas of expertise that I mentioned. And back 1 slide. And then in making appointments to the advisory committee, the board shall consider diversity of expertise on the AC or the advisory committee. Diversity that reflects the makeup of California, such as by race, ethnicity, gender, sexual orientation, or geography, as well as experience of the advisory committee member as a patient or caregiver of a patient with a chronic condition. Next slide. So here's the areas where the advisory committee will provide input and provide recommendations to the board. It's many of the key areas of the statute that the board has to grapple with. So they're listed here. And then the last bullet is other areas as requested by the board or office. So, you know, in addition, the board, the statute does say the board shall consider input, including recommendations from the advisory committee as well as public comment in their deliberative process and decision making. Next slide. So we've laid out a few options to consider for board action. We did put out a submission form for advisory committee membership, and it closed on April 15th. We received a lot of interest, and so we've laid out two options for the board to discuss, which is the office could evaluate all those submissions, review them, and then come back to the board with who the office recommends as individuals that meet the statutory criteria. And then the second option, which is the staff recommendation, is that the board could vote today to establish a subcommittee of 2 board members that would work with staff to evaluate those responses and then come back to the May meeting with a recommended slate of advisory committee members. And then, you know, we put out a third option in case there's something else that we're not thinking of that the board would like to propose. And then do want to say that in terms of the other work that the subcommittee would do is consider other details, like do we want to have a term limit of, you know, that their appointment is time limited? What's the process to add new members in the future or remove members as people transition out? So those are other kind of details that we would work with the subcommittee work through with the subcommittee. So with that, in terms of the time frame, we would propose that we return at the May 2023 board meeting to take action on appointment of the advisory committee members. And we have proposed to have the advisory committee meetings begin in June. And I'll now turn it over back to the chair for facilitation of discussion.
Okay, Don, you had your hand up first, yeah. Clarify.
Sorry, is that a turn on your microphone, throat clearing? Couple of, can you remind us, is there a number in statute on the size? So it's that's at our discretion. And similarly, just because Oregon talked a little bit about it, but we also, so that, it seems like there are a bunch of policy decisions in there, like weighting. So they made the policy decision to weight 50-50, for example. Is there any guidance in the legislation about weighting, or is it just wide open?
What do you mean weighting?
Weighting, so they have a 50-50 mix between consumer types and industry types. And they did that by design. So those are, so one of the things that may be helpful or maybe even important is thinking about sort of key policy drivers before we kick it to folks to start running through names, et cetera. And it might be how, I don't want to delay this process or make it more complicated than it needs to be, but queuing up a handful of those that are just heuristics as we do this, I think would be helpful to whatever construction, whether it's a staff construction or a subcommittee or whatever, but I think that would be really important.
Do you, while we're contemplating that, one of the 2 slides previous, I think had some of the, yeah, these, I guess, yeah, I mean, at a too high a level. Okay, before we move on to other comments, Don, I think, is suggesting we do talk about some of the attributes of folks on the board. I worry a little bit about time management right now on that point.
I'm not suggesting trying to squeeze it in the next 3 minutes. But I do, yeah. And that's why I don't want to push this off indefinitely, but I think that's an important thing. I mean, I think it's important that we, because you could go through names and then find out you have 80% industry and 3 consumer advocates, or the opposite, unless you have a general rule that that helps guide that kind of decision making. And that's one of a kind of probably a handful of key considerations that I think you would probably would be important.
Sure, thank you, Richard Payne.
Yeah, no, I mean, I think that's a good idea. I'm just thinking about how we organize this discussion in a few minutes to give guidance to whichever group. I would actually support the idea of having 2, or I don't know exactly, I would say whichever board members want to get involved perhaps, but who want to spend the time doing it, but working with the staff to come up with a list. But it would be good to have some guidance for the staff and the board members as to what the whole board would like to see in terms of its sort of composition in the end.
So before we go, Elizabeth, I hear, Richard, you suggesting that instead of a subcommittee of 2, it might involve more of us if they're depending on interest.
Who's interested?
Yes. Okay, Elizabeth.
I wanted to sort of agree with Don, and I would just recommend or request that there be a majority of non-industry, even on the advisory committee. I think, or minimum of 50-50, but those subject to the targets, I think will just have potentially different input. So if there is a composition element, I would recommend that. I would also support having board members involved in the subcommittee.
Question of clarification. My understanding is that the advisory committee would not be taking votes on anything, but would be providing input. And so I would think that, what's important is to get input from all of the interested parties from whom we would want advice. And I guess the sort of question of, whether it should be minority industry and majority consumers maybe depends in part on how much diversity, how many different consumer voices, we think are out there and that we need to hear from. We certainly know that there are many different industry voices that we know are out there and that it would probably be useful to hear from. And we, I would think very much want to hear from consumers. I guess the question of whether there are, 12 very distinct consumer perspectives, and so we need to have all 12 represented or not. I'm not sure I could name the 12, but maybe others could. I know I can name that small hospitals have different interests than large hospitals, and physician groups are going to have different interests from hospitals, et cetera, and I have some interest in hearing their perspectives. Whether I will agree with them or not is another question.
Donna,
I was just going to add that that's one of the questions that I would put on the kind of heuristics list is, are we trying to boil the ocean here and give everybody their opportunity to opine, or are we trying to, is it more practical to work with a small group of folks who are going to be sort of instrumental in answering key questions? Those are the kinds of things that I think it's helpful to have this group opine on at the front end so that we give this a little structure.
Sandra, did you want to jump in?
Well, if you want to respond to Don, I'm happy to hear that. I'm sort of wanting to raise another set of issues.
Okay. Another structure, of course, is that depending on how many of us collectively join that subcommittee, that subcommittee could, take this set of responsibilities to, first define before sitting down and selecting. So we could move in that direction where the subcommittee's responsibility isn't just to sit with staff and review who's applied, but really before even getting to the full list to sit down and then when come back to the full board to present, here's what guided the decision making. So we could go in that direction. But Sandra, go ahead.
I was just going to ask the question about why staff is recommending that a board subcommittee do this as opposed to staff doing it. So that I'm sure there was a lot of consideration for that. It'd be helpful to me just to hear what that was about.
We think it's a great opportunity for us to engage with you all. The board is ultimately going to be voting on the advisory committee members. So to have a couple of you that have sort of looked at the full set of applications, considered some of these important considerations about what the makeup of the committee should be, we thought it helpful to have a couple of board members who could then be the spokespeople for why the recommended list came forward as it did.
It should be just considered that if we are a larger than 2-person subcommittee, we then trigger Bagley-Keene, which changes certainly the cadence of moving this forward. So
I would be fully supportive of 2 board members of the board doing this work, that it not be larger, with the caveat that you'll come with rationale for size and all the other dimensions and qualifications that we talked about.
So looking at the staff's recommendation, we would just say 2 people, members of the board, willing to roll up sleeves on what are the front end characteristics, how does that then drive potentially the size, and then look at the list of potential candidates, moving with the staff that list forward, and then returning to the board to confirm. That is, it feels like a reasonable place to land, seeing heads nodding. This is we do have to actually move this forward so we can.
Board Member Lewis would like to speak.
Oh, great, thank you.
Well, let me just say I appreciate that motion, the where we're heading here, and I'm going to make a motion, but in doing so, I wanted to, for whomever the 2 committee will be, wanted to say I find myself in alignment with what Elizabeth said and really kind of lean to encouraging those 2 to to really emphasize consumers and providers or representatives of providers very heavily, and really try and see the full breadth of those two constituencies in particular. I have a hard time reading the room, but I would, since I heard a couple folks say they're open to it, perhaps suggest that we go with the staff recommendation of 2 committee, and if Elizabeth and Dr. Pan might be interested.
Sure.
If not, I would volunteer myself.
I read the legislation.
We heard sure. We didn't hear yes. We heard sure. Okay. So we.
I will second the motion then.
Okay, so we have a motion, just to be clear on what it is, to have a subcommittee of 2 people of this board. It's been put on the floor. Richard Pan, Elizabeth Mitchell represent the full board to look first at what characteristics the advisory committee would have, then determine potentially the size, and then from there review applications to determine who would be members of that committee, and then return to the board to approve that and move forward. So I'll take a few comments. We have the motion, we have a second. We'll take some comments here, then public comment, and then vote.
A brief question, I just want to be sure we don't have any violations of Bagley-Keene, is that if, for example, as we're deliberating, and of course it's the full board will decide on the appointments. If board members want to give us some comments or suggestions or ideas, if they communicate, it's okay. I just want to be clear. That's why I'm bringing it up. I just want to be sure it's legal.
But this is the time to
Right.
do that.
Bring it
And
up.
this, so let's make sure that happens here. Right.
Yeah, and when you come back, you're going to get plenty of feedback. So it's so just do a good job.
So
any prior feedback is helpful, is welcome.
But if there is critical feedback that any board member would like to give, your input now before we start the proposed structure, that would be appreciated.
Okay, to that end, other comments, questions, feedback from the board? I'll just put my nickel on, hope that we do really get to some, significant representation of non-industry voices in the room. That's what, I think will make the difference and help us drive towards, it's not in any way to diminish the role of making sure we have the diverse industry perspectives as well, but I think making sure that we strike that balance, however you 2 would see fit. We would like to put my nickel on that. Sandra, you.
I completely agree with that, Mr. Chair. I would suggest that industry folks that don't make it onto this committee will have access to this board through public comment, and often do. And so as you consider candidates, I would encourage you to consider candidates who otherwise would not have great access to this board, either virtually or otherwise.
I guess the last thing I would say is you both would, we're putting all this pressure on you 2, but frankly, I think the conversation that we had earlier, that the path that we're on, even if we kind of have a sense of what it is, making sure that we invite enough input from folks who might have some thoughts on the public health spend side or the behavioral health conundrum that we're all facing and trying to understand how we integrate. So beyond maybe the quote original view of what the guardrails were, making sure that that's represented. Okay, seeing nothing else, we'll take comments from the public.
Beth Capel, Health Access. I know it strikes me that you have a non-voting member of this board who may not trigger the same Bagley-Keene considerations and who has had a number of questions on this topic. So that But I defer to your counsel on the Begley-Keene implications. Thank you.
We'll take that into consideration and already have an answer, but in the spirit of not responding directly, you will see how that takes shape. Yes, thank you. Any other comments on the phone?
Yes, we have two hands raised at this time, taking them in that order. Craig Simmons, you're unmuted. Go ahead, please. Craig, you're unmuted on our end. You have to unmute on your end also.
There we go. Okay, sorry.
Great.
Okay. Why is organized labor as an area of expertise limited to only healthcare workers? Unions can be a great asset when it comes to healthcare and equity and affordability. So would the board consider opening, if for example, I have an area of expertise in the Teamsters Union with regards to health care. So would the board consider opening up to organized labor other than healthcare workers is my question.
Thank you for the comment. We'll move next to Cindy Keltner. Cindy, you're unmuted. Please go ahead.
Thank you. So what I would like to ask is that when you're looking at the advisory committee expertise, that you think about including representation of the safety net community or community health centers. They care for almost 8 million patients, 1 in 5 Californians. And I think it would be an important voice to have at the table. Thank you.
Thank you, Cindy. Seeing no additional hands raised, I think we've closed public comment.
Okay, so let's go around and vote on the motion. Make sure it's clear to everyone. I'm going to start on the virtually. Ian?
Aye.
Elizabeth?
Aye.
Richard?
Aye.
Sandra?
Aye.
Rick? Aye. David?
Aye.
And I'm an aye. Perfect. Thank you for willing to step in and help on this. You'll do amazing, I'm sure. Okay, just a quick time check. It is exactly 1:30. We are supposed to end in 90 minutes. That's not going to happen. We will try to keep it as short over time as possible, but we want to make sure we have a few minutes, certainly at the end, to help our ensure we have enough time for public comment. So we are going to do our best. I think we are, am I inviting Michael right away? Okay, so Michael Ballot, who we had the pleasure of meeting last time, is again with us virtually, and we will ask Michael to be succinct, board members to be the same when they're asking questions and having the discussion, and we'll see where we go, but we want to make sure we get through it. There were some optional parts of the conversation on the agenda if time permitted. Time is not going to permit us, so we will revisit some of that down the road. So Michael, thank you for being with us again.
Thank you. Good afternoon, everyone. Sorry I'm not with you in the room today.
Michael, before you start, Sandra, I think, is telling me she has a hard stop at 3. So let us do our best to see where we can go. And I am certainly willing for the public comment section to stay a little later if need be. So thank you.
Okay.
Go ahead, Michael. Thank you.
Thank you. Nice to be with you. I'm sorry I'm not in the room with you today, but I will be next month. So we are going to start the conversation about design considerations. So during our last meeting, you all got an orientation to the statute that guides your work. Vishal shared some information with you about healthcare spending in California, affordability issues, equity issues, and I introduced the concept of spending targets. As a reminder, as Vishal showed you earlier with the work plan, we're going to spend the first 3 quarters of this year focused on a methodology for measuring and reporting on total healthcare expenditures, or THCE. And then in the last quarter, we will talk about spending targets and spending target values. Next slide, please. So today we're going to focus on defining total healthcare expenditures. This is sort of a building block for other technical issues that we will deal with, and I will say more challenging ones over the next few months. Total healthcare expenditures is the basis by which the state will primarily measure performance against the spending target. It is the measure that Oregon and Massachusetts use, and frankly, all the other states with spending targets use. As a reminder, the first public reporting will be for a baseline period, which will be calendar year 2022 and 23. The regulations for data submission are to be finalized by the end of the year, with a first public report no later than June 2025. Next slide, please. So there are 4 topics that I've lined up for today. Because our time is compressed, I don't know that we're going to get to number 4, so we might pick that up at the next meeting. So they are: first, what are the components of total healthcare expenditures? The statute is definitive for some of them, but not totally for others. So we want to review the elements and ask you for any guidance you might have. Then we'll talk about whose spending is to be measured, because that's not completely specific in the statute, and there are some choices for you. And then what's the population we want to use as the denominator when we're calculating per capita spending? Okay, next slide, please. So over the course of this meeting and the meetings to come, I'm going to share with you a series of sequence design considerations. So we're breaking apart the development of the spending target and methodology into specific design questions. Every time I present one of these questions or considerations, I'm going to share options to the extent that there are options. And I will share with you what other states have done, so you've got that as context. And then we'll attempt to facilitate discussion to help you reach agreement on an approach. Our first time through all of these design considerations, I'm suggesting that you try to come to tentative agreement, but only tentative agreement. And the reason for that is there might be subsequent conversations that give you cause for wanting to go back and reconsider a prior conversation. In addition, you will not have heard from the advisory committee on its input, nor will have you received all public comment. So some of that input from the advisory committee and subsequent public comment might lead you to reconsider some of your early thoughts. So throughout this process, I want us to think about tentative considerations that you will have the opportunity to revisit. Next slide. Just a reminder, we covered this at the last meeting, but that feels like a long time ago. Total healthcare expenditures is defined as all healthcare spending in the state by public and private sources. That spending means payments, and public and private sources is inclusive of patients or consumers. And there are 5 different categories. We reviewed these last time. I'm going to walk through each of these and ask you for input that you might have where there's language that leaves some room open for consideration. You can see, for example, there's some italicized text here that says such as or including but not limited to. That means there are examples in the statute, but there's room for supplementation, and I'm going to ask you about that today. Okay. Oh, one last thing. If we can go back to the last slide, I want to note that under cost sharing, and I think I mentioned this last time, when we talk about cost sharing, we're really talking about patient obligations, because we don't have a means of knowing whether the patient share was ever actually paid. So all we know is that there was a patient obligation to make a payment. We know that, in fact, patients do not 100% of the time make payments. So I just want to note that when we talk about cost sharing. Okay, next slide, please. So as a reminder, this is the diagram we shared last time. Total healthcare expenditures has two component elements: total medical expense, which is payments for claims, non-claims based payments, and then patient cost sharing, and then insurer, admin, administrative costs and profits. This is only applied to private insurers. It's not applied to fee-for-service Medicare or to fee-for-service Medi-Cal. When we sum those two together, we get to total healthcare expenditures. Okay, so I'm going to go through the components. I'm going to start under TME with claims-based payments, and then I will proceed through the other elements and ask you to consider some design considerations. Okay, so the first one is claims-based payments. This one appears to be pretty definitive. Claims-based payments and encounters for covered healthcare benefits. And covered is emphasized because these are only payments for services that are covered under some defined benefit package. I'll note that what's covered by a commercial plan is different than what's covered by Medicare and by Medicaid. And there's even variation within those categories because Medicare Advantage might cover things that are different than traditional Medicare. And certainly commercial plans vary in terms of what they cover. So typical claims-based categories are listed here. But I think in this particular case, the statute's pretty clear on claims-based payments. I don't think we need to have a definitive list of all of the claims-based categories because basically it's anything covered by the benefit plan for which there is a claims-based payment. So it's all inclusive. We don't have to have a list of every single service. But let me pause and ask you whether you are comfortable with the clarity of the statute or whether you find there's ambiguity that we need to discuss and where you want to provide some guidance.
So Michael, I'll try to facilitate here. Rick.
Question of clarification. So dental spending is included if it's part of a comprehensive plan. Is Medi-Cal dental spending included?
Yes. So what's not included, Rick, would be a standalone dental plan. But for Medi-Cal, dental is part of the coverage.
Yeah. And granted, there's very little private long-term care insurance, but is private long-term, I assume long-term care here means Medi-Cal
right.
Long-term care. Private long-term care would not be?
Right. Private plans that cover only certain services are not included. It's only services that are covered under a comprehensive design. So Medi-Cal, as you know, covers a whole bunch of services that others don't cover. And and the vast majority of long-term care in the state is going to be under Medi-Cal. I will say that, it depends how these categories are defined. Sometimes certain services such as home health are categorized by certain states as long-term care. But yes, by and large, long-term care, we're talking about Medi-Cal.
Thank you.
Just for context, I think it's about there's almost a full third of other long-term days covered outside of Medi-Cal. So it's not an insignificant, it is the majority, but it's not an insignificant number that are paid outside of Medicaid. Okay, Richard.
Thank you. Just quickly, so for example, again, I don't know CalAIM, right? Its contract. So so in terms of claims, are we talking about? Well, there's essential health benefits, and there's things that people may cover claims for beyond that, and there's going to be variation, right? So we have CalAIM and Medi-Cal, and I don't know exactly, to what degree do we see claims for essentially non-healthcare services as part of that. And then you may have commercial plans that may, I give some provide free gym memberships. It's probably not a claim, but is there a way we're going to deal with that issue and potential variation in terms of each are we going to focus on something? Well, essential health benefits would be something that'd be common across everybody. So I don't know if CalPERS, we ever see plans that claim to have things beyond that. But I'm just wondering about in terms of variation of different things that fall under claims-based. And then, of course, when we talk about non-claims-based, then maybe we'll get into that too. So thanks.
Yeah, so covered services will vary. They'll vary by market, and they'll vary by payer within market. So the definition just says anything for which there's a claim-based payment or encounter for a covered benefit. So a gym membership is typically not a covered benefit, and there's not a claim for it.
So just to clarify, because it said healthcare benefits. In other words, if a health
Right.
insurance company provides a claim, but it's not quote healthcare, then it wouldn't count.
Right. Although, I will acknowledge that, for Medi-Cal, long-term care services, long-term care services are included by all states when they're doing this measurement. And some might argue whether or not all long-term care services are healthcare services, but I'll say practically speaking, every state includes them.
Don?
I would say, so we have a whole category of supplemental benefits on the Medicare side in our MA plan. So, for example, Uber trips to see a doctor, meals after discharge, number of these that we consider to be health intervention. They're non-health interventions, and so that's sort of falls somewhere presumably between gym memberships and paying for vaccines, right? Where do those sit?
Yeah, well, and this ties a little bit to the CalAIM question too. So particularly as there's increasing focus on addressing health-related social needs as a way to improve health status, I think that there is room for you to talk about whether you want to include spending for non-healthcare services that are provided as covered services.
Just to add, we push these hard on our plans, and we do this because we think they're good for health and good for the bottom line. And so I would, when we get to this conversation, argue strongly that they should be included.
Yeah, I mean, they certainly are covered benefits, right? They're covered benefits under a healthcare plan. Are they specifically healthcare services? No, but they certainly are covered benefits.
So, yeah, I think a lot of probably deep conversation we could have on this, both on the sort of, where we are on the mission of the state of California, what we're driving towards, what we're all pushing our plans to cover, how we think of them as critical social drivers of health and therefore related to the health work. But I think, Rick, your question is, how do you even unwind some of it? Yeah, I'm not sure how.
As a practical matter, Michael, how would you decide, what, if it's a covered benefit by the comprehensive plan and they've paid something for it, how would you give them instructions about what to include and what not to include? Seems like it'd make life much more complicated if we were trying to parse what's healthcare and what's not.
Yeah, well, so generally states don't. If it's covered, then it's in.
Okay, I think that's helpful. So again, these claim-based categories are what you put up as examples, but there are additional ones that we all might see as missing from this shorter list, but they would be included. David, Carlisle, anything?
Yeah, just another item under the umbrella that you just mentioned, but it may be a rabbit hole, but in dental care, for example, and just as an example, increasingly common are extra billing practices that exceed plan coverage for patients. And so the consumer patient is actually getting hit with a bigger bill than coverage would indicate. Do we intend to capture that as well? It's a large percentage of dental revenue.
I think related to even some of the points we brought up about behavioral health and some of these other sort of on top of whether it's part of the coverage or just not covered and people are going to get it there. I think we're going to have to grapple with that.
Yeah, I mean,
Okay.
really all that we know is what's the allowed amount that a payer can tell us about. If there are payments that are happening outside of or above and beyond the allowed amount for a claim, you don't have any means for knowing about it.
Elizabeth, do you want to jump in? Just even a comment? Yes.
Only that's just going to be.
Is it on?
Yep.
Yeah, it is.
Only that will be really inadequate measuring affordability. And I don't have an answer, but those out-of-pocket costs are growing regularly. And we're looking at affordability. One question I have, and we can address this later, but I assume we will be able to sort of calibrate within this limit what we want to increase versus decrease. I mean, or is it going to be segmented somehow, or it's just going to be a simple limit?
I assumed a little bit like you, only because we have a focus on primary care spend as well, but I'm not sure practically, as a practical matter, how we're going to do that.
I can share with you that other states that have an overall spending target, but have set separate targets, particularly for primary care, have instructed payer and provider organizations that the way that they will hit both the spending target and the primary care spend target is to have primary care grow faster than other services so that you can both hit the primary care spend target and hit the overall spending target. So it's essentially redistributing or varying spending growth underneath the spending target without actually setting separate targets for service categories.
Could I just go on the record saying that I hope we can do more than that, because then we just sort of leave it up to the plans to do the redistribution, which I would worry about.
Yeah, and for me, just to build on that, it becomes a bit of a practical matter. Like, how would we do what you're suggesting versus what Michael says is the tradition, and understanding that and getting clarity on why one versus the other is maybe the only possibility, not sure, and what we do to work through that. So I think it's a fair point. I am doing a terrible job remembering Ian. So Ian, I'm not sure if you have your hand up, but if you want to weigh in, please do.
Thank you. I'm good at this time.
Okay, thanks. Okay, we should, for the sake of our time, keep moving.
Okay, so the second category is non-claims payments, and statute is less definitive here. You can see that such as language. So it provides examples. The non-claims categories, I'm going to share with you examples, but both those in the statute and additional ones outside of the statute. But I want to note that the office has to separately consider standards to promote alternative payment model adoption. And so it will need to be spending some time separately thinking about non-claims categories. And so my suggestion is we look at some examples today, ask you what's missing, but then come back to this conversation after state staff have had time to think about this in the context of APM adoption. So next slide, please. So these are examples identified in the statute. I'm not going to read through all of them. I think capitation, you understand. Salary, you understand. That's primarily going to be for something like a staff model HMO. Global budget is prospective payment for a comprehensive set of services. Most commonly in some other states, this is being explored for hospital payments, hospital global budgets. Medi-Cal and all Medicaid programs nationally have lots of supplemental provider payments that they make to providers. Elizabeth, do you want to add anything on this?
Yes, I just wanted to call out that we have been meeting with DHCS to start working together with them to lay out all of the different supplemental payments, right? So we all know that Medi-Cal financing is incredibly complicated, but we will be gathering data on some of the, supplemental payments to public hospitals, some of the supplemental payments to clinics. To the point about behavioral health, when we were talking about public health earlier, certainly to the extent Medi-Cal is paying for specialty mental health services at the county level, that would also be included in some of the Medi-Cal supplemental payments. I hadn't thought as much about fee-for-service dental, but I think we'd want to capture fee-for-service dental. So we have started that work with DHCS to lay out all the various supplemental payments.
Thanks. So the next two slides have 7 other examples that other states use that are not specifically in the statute. First one are something called infrastructure payments or population health payments that are to help expand provider capacity and support infrastructure. It's especially common for primary care. Case rate payments, which are common for obstetrics and for some other services. Episode-based payments, which can be made both prospectively and retrospectively, but here is listed as prospective episode-based payments. Then the next slide, 4 more. Separate performance incentive payments, such as in a pay-for-performance program. Recoveries and pharmacy rebates are really negative payments. And then a catch-all other category for grants, surplus payments, other payments that don't fit into the categories. So there's a wide array of non-claims-based spending. Non-claims-based spending is particularly high in California because of the broad use of capitation, but there are other forms of non-claims-based spending as well. And there will be time to consider the level of nuance for reporting from payers for non-claims spending and how much detail it will be valuable to get from the payers for analysis and reporting. So the next slide lists all of these examples of categories, both those in the statute and others that are used in other states. Are there any other categories of non-claims-based payments that you think should be considered?
I have potentially a couple, just these are sort of in the opposite of incentive category, but so on our pharmaceutical benefit manager contract, for example, we have guarantees that we benchmark to the rest of the market, and we have a negotiated sort of amount that we're supposed to match up. So we will occasionally get a large check because the prices we're getting are not as good as they should be. So that is one category of things. And then the other category of things, which is new, and maybe these are also in the sort of reverse from incentives, but we have all sorts of penalties that we impose on health plans, and a handful of new really important ones related to the 4 measures that cover California, Medi-Cal and CalPERS have agreed on and are in all of our contracts to a certain extent, covered and CalPERS completely. But where if they fail to meet the metrics, they have they owe significant money back to the purchaser, and wondering how we factor that in.
Yeah, so those are sort of additional categories of negative payments, right? That's an offset against your admin.
I wonder whether those are better dealt with under the insurer administration and profit part as changes to what the insurer is either making or not, rather than trying to kind of associate with individual patients.
Yeah, I think that is where they belong.
Maybe, I mean, there's also a policy question in there, because what we don't want is for people to be hitting their spending targets by missing the quality marks, for example.
Others before we move on.
sorry.
If
this
I
is
may,
just a
Dr. Gell.
question.
Oh, we'll let Ian go first and then Elizabeth. Is that okay? Go ahead, Ian.
Thank you. Just two things. One, not to beat a dead horse, but just to make sure it's explicit here. I do think cash payments needs to be recognized, even though that's very, very hard to quantify in behavioral health, especially, but elsewhere in the health system. And then just in terms of nuance, I think the distinction between capitated payments to plans and capitated payments by plans to providers are two very different beasts. And I'd like at some point to hear a little bit more about when we expect those two pieces to be teased out of the HPD. I know it's not this summer, but will it be by the end of the year? And if not, how do we capture estimates of those in a timely basis?
Thanks, Ian. Good
Can I
flags.
respond to Ian's two?
Please.
So, Ian, we've talked about this. Cash payments are significant. The challenge is finding a data source to measure them, because we don't have a source for spending data aside from what payers can give to us. And so we know that there's a fair amount of it, especially as we've got increasing people paying out of pocket for mental health services and for other services, but there's just not a systematic way of capturing that spending. So I would say that this methodology, while comprehensive, is imperfect for that reason. And the delegated arrangements, this is something that we've been researching because it has a lot of impact on how we measure performance of provider entities, because there is so much delegation that goes on in California. I don't know that the HPD answer, because the HPD is not going to be our data source, but we are currently conducting some interviews with health plans to understand their contracting arrangements, to get a sense of what we will be able to access and what we won't be able to access.
Thank you.
Rick, did you want to respond to this? Or
I did. I mean, I think, Ian's point, which we've discussed before, is, I think also, particularly in behavioral health, crucially important that, maybe something like a third of behavioral health spending is just out of pocket for covered benefits, but, the network isn't good enough. And I understand that we can't get that information from the health plans because they don't have it. But I think we need to put effort into figuring out how we can best estimate it, which might be from, survey-based California Health Interview Survey, might be from trying to count how many psychologists and therapists there are in the state and estimate what their income is and how much of that is coming from. I mean, I don't know, but we're not going to solve the problem now, but I think we have put serious effort into it and not just ignore it.
Well, and Elizabeth said, we are here at HCI where this body lives. We have a number of state partners who have access to information to help us on this front.
Actually, had questions to licensure.
So there's I think it is worth us digging in. I would just strongly echo what we're talking about, especially on the behavioral health side. I think the dental piece is interesting, but this could be and Michael, with your assistance and Vishal and Elizabeth, really dig into this as we move forward.
And then secondly, following up on another point that Ian raised and that Michael responded to, we've talked, and crucially important, to figuring out a primary care benchmark, behavioral health benchmark, and kind of how that changes over time. Given the widespread use of capitation, that's going to be hard to do from the claims information we're getting from insurers. And, again, a plan is needed. My first thought would be, assuming the HPD would support it, to using the HPD to get estimates of kind of how much of the capitation is going to one service versus another. Again, we're not going to solve this now, but we need a plan for solving it.
Okay, Elizabeth, did you want to? No, you're good. Sandra?
I think Rick's point around finding some proxy estimate by which we try to understand the out-of-pocket behavioral payments. We just need to agree on a methodology for how we consider it across the behavioral health spend and the global spend.
Yeah, okay.
So why don't we look into this and we'll come back to you whether we think that there's a valid source for estimating out-of-pocket mental health spending. And then you can make a recommendation as to whether you want to supplement the payer reported data with the estimate.
Can I just rephrase it a little bit? Could you maybe come back, the team, with what the best approach would be, whether then you think it's valid, and then we can decide? Because I think you're hearing a hunger from the members here that we want to find a way to do this, even if imperfect, at least really kick the tires on it. So I'd appreciate that on behalf of all of us. Elizabeth, yes, go ahead. Yeah.
Totally agree, but I wouldn't limit it to mental health. It's dental, it's doula care, it's all sorts of things. So,
and the approach may be a little different depending on what we're trying to capture. Similarities, but different. Okay. All right. We're our own worst enemy to get to the 3 o'clock end time, but we are. That's what we're here to do. So let's keep going, Michael.
Okay. So our next category is cost sharing. So the statute, I'm sorry, can you go back? Can you go back a slide, please? Thanks. So the statute, again, is not definitive here because it says including but not limited to, and it cites 3 aspects of cost sharing, copayments, coinsurance, and deductibles. So I think we want to explore, are there any other categories of cost sharing for covered health benefits? I want to emphasize covered health benefits, not non-covered health benefits, but covered health benefits that we might want to include. Next slide. And as we think about additional categories for inclusion, we can also consider whether there's anything we want to explicitly exclude. And again, as a reminder, payers generally lack spending data for non-covered services. So anything else that we should be including for cost sharing, or is there anything you want to explicitly exclude for clarity?
Go ahead, Rich.
I guess and this is probably a broader comment than just this specific thing, but I think in terms of as we're trying to establish this total health expenditure target and so forth, I guess I have a little concern that we want to be sure we have apples to apples from year to year, and that if there's variation in what gets covered and which plans cover what, and we already talked about the variations in that, and then of course, you know, here in the cost sharing, et cetera, that that we're capturing the trend for a fairly consistent set of services that we've decided that we're collecting the data for, so that we don't so that changes in basically behaviors of individual plans or medical groups or whatever else, if that's changing, then of course that could have an effect on the total expenditure and could make it harder to compare. So I guess one question is that how much variation do we might expect to see over time, especially, as I said, we've now having CalAIM, right? There are people moving in directions to covering things they didn't cover before. And so I guess I just want to make that point, and whether you had some thoughts on that.
What's covered generally doesn't change significantly year to year. I'd say CalAIM is an exception. What has changed significantly over the last decade has been the amount of cost sharing in the commercial market, and that has a significant impact on patient behavior. But the covered services themselves, most years change only marginally.
Okay, well, I think, as you said, pointed out, CalAIM is an example where things are changing. So I just put that as a caveat that we need to keep an eye on to be sure that as we're over time, and admittedly we're just at the beginning of the journey, that we keep an eye on that. And there may be lots of good reasons why additional things are being covered, right, over time. So something just to keep an eye on.
I'll just echo that because I think just thinking about where the state hopes to move on behavioral health, for example, ensuring that benefits that are covered maybe under Medicaid get covered in some of the broader commercial plans. I think that could be a significant shift that if successful and we work on that. To your point, Richard, I think it could be material, so keeping our eye on that.
The non-medical health interventions, another
Yeah.
great example of that.
Right. David.
So I guess, Michael, thanks for the great presentation again. To your second question, I think you're hearing significant feedback from the board that maybe the answer is no to the second question. And I'm just thinking of the probably one of the more onerous categories of cost increases that the consumer patient is facing are surprise bills that come from healthcare encounters that can be thousands of dollars because they think something is covered and it turns out not to be covered, or a provider is not covered that they thought was covered, et cetera, et cetera. That's one of the major categories of complaints that I think we're hearing today.
So, David, are you advocating for including spending on non-covered services in THCE?
Well, I think I'm advocating for saying no to explicitly exclude. I'm not sure what or how to include yet.
Yeah, I think that's, and Michael, there's a good bit of head nodding in support of that point that David's punctuating on behalf of our body.
Okay, thanks.
Okay.
Yeah, I guess I would say is that you said, yeah, it's not covered, but it's actually a service that's healthcare that should be covered in some way, but so no, it's not covered because they're out of network or something. It's not because the service itself. So that you consider that still healthcare spending. Come here, Michael. Okay, sorry. I thought I had my mic on. So anyway, in brief, I said that's still healthcare spending. It's because of the nature of the health plan and the relationship with the network and not having a contract. It's not because it's not healthcare spending. And so how do we capture that?
Yeah, I mean, I honestly don't know if we can. But, following the request earlier that you all made about seeing if we can develop an estimate for spending, we can look into it.
I guess quickly, you have claims that health plans receive. You have bills that hospitals send. So I don't know. Is there, again, so I don't know, denied claims, bills that are unpaid, et cetera. I mean, again, sort of like you said, in terms of your copays, we don't know how much someone actually ended up spending, but we know someone got a charge or they got billed for it.
Yeah, I think the point, Richard, you're punctuating it. Let's really grapple with what's the right way to do it. Bring a suggestion back to the board, and we'd love to kick it around. Okay. Keep going, Michael, please. Thank you.
Yep. Okay, so the next slide, the next component is ensure admin costs and profits. We have more included but not limited to language. So you can see it's defined as having 5 component elements. I'm not going to read them, but you can see them all. So my question for you is there anything that's missing from this list of 5?
If I may.
Yes, Ian.
Yeah, this is just an open question, but I think, with health plans, large health plans that predominate here, their relationships with particularly the integrated ones with associated entities, I've never understood, or I've never been convinced that the official definition of medical loss ratio really reflects what it does in other settings. And so in those cases, I'd want to really put a close microscope to figure out, are we capturing all the profits and losses there?
So Ian, you're not questioning the categories, but whether we are adequately capturing the spending associated with those categories. Is that right?
That's right, and whether it's truly applicable to the entity in question, whatever that is. Yeah.
And Michael, does that make sense to you?
It does. I'm not sure to act upon how to act upon it. However, any suggestions you've got, Ian, on where to take that?
I don't at this time. No, I think it's something we're going to have to grapple with. I certainly wouldn't expect anybody here have a simple answer to a very complex set of relationships. Just wanted to flag it as something we tackle down the road.
Mm-hmm.
Yeah,
something that I
fair-
have
fair
heard
point.
mentioned, and I don't have an answer for this either, is that with all of the levels of delegation, there are administrative functions that are being delegated to provider organizations.
Right.
And because of the nature of the contracting, which is largely capitation based, we get very little insight into the administrative costs that have been delegated by the payer to one or multiple levels of provider entities.
Yeah, it's a very good point that I think our Medicaid program has learned a lot about over the course of many years. Okay, Richard.
Yeah, just briefly, this all categories of administrative expenditures, and, of course, I voted to help write the statute, is kind of a little bit of a catch-all term. So we want to be sure we're consistent in being sure that category actually captures administrative expenses. We had a little conversation about executive pay compared to frontline worker pay before. So we may want to parse out to be sure that that all categories of administrative expenditure is capturing what it's supposed to capture with all the plans. And as mentioned before, there's also the problem of essentially delegating some of those expenses, and how does that get captured as well?
And the point you're making maybe connects to what Ian's point was. Like, are we really getting the right volume of information on any one of these areas that helps it be a fair judge of the true administrative costs and profits? Okay, other points on this? Okay, keep going, Michael.
Okay, so we've covered the elements of total healthcare expenditures, and you provided input. This next question is a completely separate one. This is talking about whose spending we're going to be measuring when we measure against the spending target. Next slide, please. The statute says all healthcare spending in the state by public and private sources. It's not clear what spending in the state means. And so I want to pose two questions to you. When we're capturing spending in the state, what does that mean in terms of the residence of the individual for whom the spending was made, or who made the spending, or both? And what does it say about the location of the provider who delivered the services and who received the payment? So I'm going to lay out 4 scenarios for you. I think the answer to 2 of them is obvious. The answer to the other 2, though, I want to invite you to consider. So the next slide has the 4 options. The top left is a California resident receiving services from a California provider. That we've got a check mark by that because that seems to be an obvious yes, we want to include that spending. The bottom right box is an out-of-state resident receiving services from an out-of-state provider. I think we probably don't want to include that as California spending. But the other 2 boxes I want you to consider. So in the top right, a California resident receiving services from an out-of-state provider. And in the bottom left, an out-of-state resident receiving services in California. So let's look at those two question mark boxes. So first, California resident care from an out-of-state provider. So there are California provider organizations that have affiliated or employed physicians who are across the border. There are also residents who split their time between California and other states, either for seasonal living or they're traveling for work or vacation. In terms of other states, all of the other states that have spending targets have made the decision to include spending for services received by state residents from providers who are out of state. So if it's a state resident, the spending's in, regardless of where they receive the services. The second scenario is a non-state resident who receives services in state. So state employees and other workers who work in state frequently live across state border and commute into the state for work and receive their health care in the state. And their healthcare benefits are covered by California employers. If we want to include that spending, we'll only be able to capture it with certainty from insurers that are going to be required to report to the state. So those are likely to be insurers that are licensed in the state. So for example, if somebody's covered by Blue Cross Blue Shield of Alabama, you're probably not going to get their spending. So this is spending in California, but not on behalf of state residents. And the other states with spending targets have decided not to include this type of expenditures. I will say that in some of those states, this has been a source of more extensive debate where there have been some people who have advocated for it, but ultimately all the other states decided not to include this type of expenditure. Next slide, please. Okay, so here's the question. What do you think we should do with those two boxes, the top right and the bottom left?
So we have a person with lots of real life experience on this.
We have people who fall into all of these boxes. We have a few thousand California residents who are living out of state because their job requires that they live out of state. So we have 10 people in Hawaii who are doing agricultural inspections when you get on the plane going back, and hundreds in New York and Illinois and Texas. We have people who retire out of state, some of whom maintain a California residence, some of whom don't maintain a California residence. And then we have people we have workers, we have a plan that is designed, Salud Mas, which is designed to pay for care in Mexico and in California. So we care deeply about the rates that are on those plans. So that seems really important. So we have a Kaiser out-of-state plan that's just for people living out of state. For Kaiser only, we have plans that cover California and other states. But I'm just flagging it. So I have no idea what we should be doing, but we care for different reasons about all of those different categories of people. And we have real affordability issues. Right now, we're grappling with this challenge of people who are working out of state, but don't have access to good affordable plans, because we have somewhat affordable plans and some not very, and some very affordable plans and some not affordable plans. So it's something that we're paying a lot of attention to, and affordability can be a real issue for those folks.
As you consider these questions, I would encourage you to think, what's the purpose of your spending target program?
Yeah, good advice, Richard.
I have to admit, I'm kind of leaning toward what I think most of the other states all have concluded, which is that we're a state agency. We take care of California residents who have an out-of-state provider, that gets included. If you're out-of-state resident in California, we certainly care about them, and for lots of reasons, CalPERS, et cetera. If you're actually the provider, I mean, it matters, but I'm not sure whether that actually helps, or it probably adds a layer of complexity that frankly, in terms of our mission and what we're supposed to do, that's maybe that it doesn't add a lot. So I think just it adds challenges that probably doesn't really move the needle much for us.
David.
Yeah, I was going to, I echo Richard's perspective and argument for symmetry, especially for comparability across the different states. But Don's comment definitely resonated with me. And my question would be, what do the other states do with those spending patterns? Oregon, Massachusetts, do they have a CalPERS-like entity that has to wrestle with these questions?
They do.
Yeah, they do.
They do.
And Massachusetts certainly is a lot closer to other states than we are. So,
yeah.
Plus they have the sheiks coming in from the Middle East for.
Other comments? So just to be clear, Michael, do you need us to give you definitive direction now, or we can, Vishal, Michael, what's the?
I mean, it would be good to get your leaning on all of these. It sounds like you're leaning towards doing what the other states have done. We don't need a decision, but getting your leaning is helpful.
Yeah, if we agree with Richard Pan's sort of summary and alignment with the other states.
Okay. Okay, great. Let's move on to the next slide. Okay, so the next question is, what sources of healthcare coverage, because we are measuring covered services, what are the sources of healthcare spending coverage that we want to include for public and private? So all the other states include Medicare, fee-for-service, and Medicare Advantage, Medicaid, managed care and fee-for-service, to the extent that there are integrated Medicare, Medicaid plans for persons who are duly eligible, they include that spending, and commercial fully and self-insured. There are at least 4 other sources for possible inclusion that you see listed here, and I'd like to review each of these for you and get your input, and then ask you, are there other sources of coverage for inclusion? And I want to make note and acknowledge the public health conversation we had earlier today and during the last meeting. I would say those are not sources of coverage per se, but clearly you've got interest in it, and we might want to come back to that topic. All right, next slide, please. Okay, so correctional health system, this is state correctional health system, not federal. In 2018, about 0.5% of the state population was incarcerated. This spending, in my experience in other states, is typically available. It's not going to be available using the same methodology that we would use with other major payers, but there should at least be an aggregate spending amount that that we would be able to obtain without too much difficulty. And I'm saying this just based on experience in other states, because we have not investigated it fully for California. So it should be available. You can see here, Connecticut, Oregon, and Washington all include state correctional health spending in their calculations. All of these categories are going to be very small individually, and even combined, they're going to be small relative to Medicare, Medicaid, and commercial. But other states have considered these categories and added them with the goal of being as comprehensive as possible. The Indian Health Service, we don't know the exact spending. We know that about 1.5% of the state population in 2020 was Native American or Alaskan Native. It's pretty certain that not all of them were served by the Indian Health Service, but presumably some percentage of them were. There are no other states that are currently receiving Indian Health Service spending and including it in their spending target program. I know from experience that Washington, Oregon, and Nevada all consider this. In order to get this information, it requires obtaining consent from the tribes in the state, and that requires a tribal consultation. And the other states either considered it and chose not to do it, or took some initial steps to schedule tribal consultation and then didn't follow through. So there are no states that have actually actively sought access to this spending data. The last thing I want to note in this slide, and this is the footnote for correctional health system, is that some of the spending for people in the state correctional health system is covered by Medi-Cal, and in fact, Medi-Cal is looking to expand coverage, as you can see in the footnote. So this would be for spending that's not already covered by Medi-Cal. Okay, why don't we pause here? Yeah, why don't we pause on that prior slide and talk about these two.
Okay, Sandra, then Rick, then Richard.
Yeah, I you know, speaking to the correctional health system, both because of where Medi-Cal's going, but also because we provide a lot of care, quote unquote, care in our incarcerated system in the state. And I think it's important to include that. And over time, as Medi-Cal captures the 90-day piece, that will get factored in on a standardized way through Medi-Cal. But I definitely think we have a lot of behavioral health workforce in our jails to the extent that we have behavioral health workforce. And I think it's important for us to include that.
Echo that, Rick.
You know, at the risk of derailing, when I was looking at these slides before the meeting, I had a very hard time with thinking about how to answer some of these without first answering, I think, the next question, which is what's the denominator? And at the risk of derailing, I wonder whether it might make sense to think about what's the denominator. In particular, to me, on the denominator, you had the choice of, you know, sort of adding up all the people covered by Medicare, Medi-Cal, commercial insurance, and so using that as the denominator, or using the whole state population as the denominator. In the first, I have trouble kind of getting, given how many people have double coverage. I mean, the Medicare, Medi-Cal, obviously we can easily measure, but Medi-Cal commercial, we can't measure so well. People are covered by 2 different commercial plans over the course of a year. And so for me, it made sense to go to the whole state population as the denominator. And if that's where we go, then I think the answers to these are pretty clear that we should include everything we can. But if I'm wrong and we end up with not the whole state population, but rather the kind of individual coverage as the denominators, then maybe the answers to these would be different.
I think it's a fair point, Michael. Do you have input on that?
Yeah. So for these categories, you're not going to be reporting, or I don't think you would be reporting trend on them because they're so small. So you probably would just be aggregating them into your state total for measuring state spending. And at that level, you could, because they're so small, you could either not worry about including them in the denominator, or you could get an estimate from, in this case, the correctional health system on the number of people they served and some type of measure of member months, which is what you would use for the 3 major markets, and include that. But again, at 0.6% of the state population, and with some of it already covered by Medicare, it's not going to influence the statewide numbers in terms of trend in a major way.
Can I just, one counter, or not counter, a question? When we get to sector-specific thinking and goals, will that change? And I guess the point is, again, if you look at behavioral health spend in the correctional space, especially when you're looking at those with severe conditions, a lot of it, unfortunately, in California is trying to take steps to change this, happens within incarcerated settings. It's a pretty significant part of not just the spend, but the workforce. And it's often invisible in how we think about, if you want to, like the sector specific approach. So I wonder if it's relevant there, and your thoughts on that.
I mean, it's just, if your overall goal is to utilize the spending target as a means for transparency and to advance affordability, I would say that patterns of spending within the correctional health system for 0.5% of the population probably isn't going to be your priority. I'm not diminishing the importance of behavioral health for people in the correctional health system. I'm just looking at the broader purpose of the spending target.
Could I get in queue, Dr.
Okay.
Gully?
Yeah, no, we'll go Richard and then Ian.
Okay.
Go ahead, Richard.
So first of all, I would make note that, as you made note, Dr. Ghaly, that oftentimes our correctional facilities, or at least our jails, are our largest mental health facilities in our localities. It's been noted. So my guess is, even if the population, again, this is the correctional, it's small, the level of care is fairly intense and high. So especially if we're talking behavioral health. So I think we should look at that information and data. If it turns out in the long run it's a rounding figure and stuff, and it takes a lot of work to get it, that's one thing. But at least the scratch the surface indication is that it may be significant, even if the population's small. I'm going to jump the gun a little bit and say, we're going to get to the veterans. We have a lot of veterans in the state. I have a lot of veterans here in Sacramento, so we should probably, I think that the denominator is the entire population. Another group that's kind of missing, although it's our county medical, the indigent services programs as well. So aside from our Medi-Cal, Medicare, et cetera. So don't forget those as well. So hopefully you can add that to the list. And again, they've been shrinking because we've been expanding Medi-Cal. So hopefully maybe that becomes a rounding figure, but certainly that's another area where we're capturing people who aren't getting access to healthcare in other means, and that is a county responsibility. Thanks.
If you are interested in looking at service level spending within correctional health, which is what I'm hearing from you, then I think we probably need to have some conversations with the correctional health system about what data would be available, both in terms of getting spending by service category, which I hear is your interest, and also whether we can get a population count that looks something akin to member months to be consistent with what we're doing in the major 3 markets.
Yeah, I think fair point, probably worth a little bit more detailed conversation. The staff working with you and getting input from all of us on how to think through that. I think we have some experience now thinking through these issues, and probably have some reasonably accurate answers to the questions you'll raise. Go ahead, Rick.
If I can try to follow up more directly, because maybe I didn't ask the question as directly as I should have. In a few slides, we're going to get population denominator for calculating statewide per capita spending question. And 2 choices. One is membership figures reported by the payers, which is used in 4 states, and one is the state's total population, which is used in Massachusetts. In the 4 states that use membership figures reported by payers, how do they deal with the double coverage problem? That is, there are many people with more than one kind of coverage. And if you're trying to estimate spending per capita, it seems like you're getting a very biased, those 4 states would be getting a very biased estimate of spending per capita, because they've got spending more or less right in the numerator, but in the denominator is going to be too big. You're going to have more people in the denominator than are really there.
They only report when they're primary, Rick. So they report
How do
on
they, I
both.
mean, but you, during the course of a year, you've got, people who are covered both by Medi-Cal for part of the year and by commercial for part of
Oh,
the year, or by one commercial
yeah.
plan for part of the
So
year and another.
they
commercial for part
report
of the year.
member months. So if they're 6 months on Medi-Cal and 6 months commercial, then they're going to have their 6 months reported separately by the two payers, or by the one payer for two different markets. Does that make
So
sense?
the dual eligibles are kind of Medicare is primary, and so Medi-Cal doesn't report.
Yeah, so for dual eligibles, unless they're in an integrated plan, then Medicare is going to report their Medicare spending, and Medicaid's going to report their Medicaid spending.
But Medicaid won't report their months, or they won't be counted because they're secondary.
Well, I think, to be honest, I think in that case, their member months are being counted twice
So it's,
for dual eligibles. Yeah.
again, to me, it makes more sense in a lot of ways to do the state's total population as a denominator. And if we are going to do that, then to me, that would argue for including everything we possibly can in the numerator.
And Michael, just to cut to the chase, let's jump to that slide because I think Rick's point is a good one. Maybe we can go to that decision if you don't mind indulging us.
Can I add
Sure.
one other, just a question, quick question?
Sure.
I did not hear workers' compensation mentioned here.
Yeah, there's only one state that captures workers' compensation spending. That's because, and it's Washington, and that's because the state administers healthcare spending for the workers' comp program. They've got a pool and they contract spending. Other states do not include it because it would involve engaging a whole different group of carriers who otherwise that's essentially it. There's a whole different set of insurance carriers involved in the workers' comp market that are not involved in health insurance.
Yeah, I think we're sort of up against the same thing we've come up to a few times. It seems really important to not include it, even though we agree it's probably hard to figure out how to include. So I think, again, do we ask people to stretch themselves to see what can be done on this point? And if nothing, nothing. And if something, we can hear back. So I think I'd include this on our list of, let's see if we can push the envelope and see how to do it. I didn't mean to say, let's skip over all of these important decisions. I just think Rick's ordering does make sense. So maybe we can jump to what is our denominator? And that question, one thing that I'm cognizant of is that Massachusetts is the only state to include the entire population, was the one that started this first, has a statute that they haven't been
It's
able
88.
to. Slide 88.
Oh,
There
no,
we
I'm
go.
sorry. Sorry.
Oh,
No,
yeah.
go back. Yeah,
Here it
that's
is.
it. Yeah, I'm sorry. I was wrong.
So, Michael, as we try to make this decision, and I think lots of folks leaning towards the entire state population, my only question is, the states that more recently started their efforts chose membership figures, not state population. Is there a reason why that's the case? And if Massachusetts, if David were still on, and they were able to have more flexibility in their statute, would have they used member figures for a specific reason or not?
Yeah, it's a good question. I have not asked David that question. As David indicated, they are bound by statutory language, which is tied their hands. I know that the other states chose not to use it because they saw significant inconsistencies between the aggregated counts that they had from all their payers and what they were seeing in the state population. And it felt better to them doing a roll-up of all of the payer submitted data to get at the member months, even when they couldn't get it for some of the small populations like correctional health, than to use a state population number that seemed quite different than the aggregated member months count that they had.
Okay, Richard first, then Rick.
Yeah, so question, if they're just using membership for payers, are they essentially excluding people who are uninsured who then also use healthcare, but then either go broke or essentially they're subsidized because they can't pay anyway by the people who are insured? So
Yeah, so Massachusetts would be, I mean, Massachusetts uninsured population is tiny, tiny, but yes, they are essentially including the uninsured when they use their whole state population. Even though their spending is not being captured because they have no means for capturing it.
Right, but that means that the states that don't aren't are basically uninsured or out, even though they may affect its expenditures.
Yeah, well, although the reason is that they don't have a means for capturing spending for people without insurance.
Well, the money's being spent on them and it's being cross-subsidized.
Oh, I agree. I agree. It's just this is like capturing spending on non-covered services. There's not an available data source. So is there a way to develop an estimate, as we talked about perhaps doing for non-covered services? Yeah, perhaps there is, but the other states have developed their methodologies using data that they can get from administrative data they can get from an external source. And when there is no source for data, they've not included the spending, including people who are not insured and may or may not be paying out of pocket for some of that expense.
Okay, Rick and then Ian.
Michael, when you say they went with the membership data because of the discrepancies, can you say a little more about the discrepancies? Were they finding kind of the state population is much larger than the sum of the membership data?
Yeah, although I remember one example
accounted for by the uninsured.
It was where the state population figure was actually lower than the aggregated member months. And so
that's the double coverage problem that I mentioned.
Yeah, that's your.
that might be the double coverage problem.
Yeah.
Or might not. I mean, I just can't explain it. They just felt that for internal consistency purposes, being able to tie out the state level numbers to the component elements was cleaner than using a completely separate data source, which would be census data, and using that as the denominator below the spending data that came from the administrative sources. And I am not I'm not recommending one approach or the other. And I think they are both fair to consider. I'm just trying to explain why the other states chose to do differently. And by the way, I'd be happy to follow up with David Seltz and ask him what Massachusetts would do if they had the flexibility.
Ian, go ahead.
Yeah, this is just back on the numerator, but I just urge us wherever practical to capture as much of this spending as possible and recognize that the acronym THCE is not actually, it may not actually represent all total, in reality, total healthcare expenditures, just technically that which the target applies to could be different. I've watched the state struggle to define how much we're really spending across all these categories, including some of the ones we skipped over, the federal spending, which is crucially important for other, health reform questions that are before the legislature, including unified financing and the like. So I just urge us, since we're charged with figuring this out, just wherever possible, are on the side of capturing the data.
Yeah, important point, Ian. David?
Yes, I think I come down more on the entire population, but it's probably more for a methodology philosophy than anything else, which is to always get as much data as you can and then parse it later. I wouldn't want to start out by excluding certain categories if we don't necessarily have to. But that's just been my approach in general. We can always come back to reevaluating the data and our ability to analyze it subsequently.
Yeah, just thinking about the simple math question that we're going to grapple with, the size, really, to your point, Rick, the size of the denominator, it'd be interesting to see what the difference is in the two approaches. I'm not saying let's run it two different ways. That would be head scratching, but it feels like it could really lead to a very different outcome based on this choice. So I don't want to take it lightly, given to the question, what are we driving towards? So appreciate the conversation that we're having, Elizabeth.
I may just be building on that, but I keep hearing us come back to the data constraints. I understand that, but I don't want to just look under the light post, because we'll be 10 years later and not having looked at affordability. We're just looking at what plans pay. So I just hope we can get quite creative and inclusive about data collection. Go to the collection agencies and find out what hasn't been paid. I hope we don't just limit ourselves to the traditional APCD approach, because that's not going to get us the information we need.
Sandra.
Yeah, I would have welcomed what Massachusetts would have responded to, of whether they would have changed the methodology in their denominator calculation. My inclination is to use the population-based data and be as inclusive as possible, in part because we do want to have an equity look at this all in from start to end. And we have a lot of people who are not counted and not in the system, that we would like to understand what we're spending on them. And so caveat being, I'd love to know what Massachusetts learned from their 10-year experiment, but my inclination would be to use a population-based denominator.
So
I just want to know. Yeah, go ahead.
You go ahead, Michael. I'll go after you.
I'm hearing a couple of ideas being conflated. One is using a state population for the denominator, and the other is being as inclusive as possible about all forms of spending, which is the numerator.
Yeah, and I would say my statement was they have to go together, because if your denominator is larger than what you're capturing on the spend, your target, just channeling my 7th grader, I'd be a little worried that we end up with a number that is lower than actual, right? Because we're using a larger denominator. So and Rick, I think this is your entire point. Let's make these, let's consider these in the reverse order that we had. Let's make sure we talk about what our denominator is going to be, and then structure what we're trying to capture on the spend side to be as inclusive as possible of everything that we need to kind of do right by that denominator, if you will. And so when we go back to those other questions, should be inclusive of correctional or, the small plan, the VA piece, I think we're going to tend as a group to say state total population as a denominator, include all we can that we can capture, even if it requires some creativity and pushing the envelope, to Elizabeth's point. That's where we would suspect we go. I would be interested to hear David's response to the question, just to make sure we're not missing an obvious point. But notwithstanding that, I think that's where this group is heading.
Okay, I'll follow up with David.
I see everyone else's head nodding, but okay, Ian's head is nodding too. There we go.
I was just going to flag, Michael, if you could speak about that asterisk. I think that is an important point about payer membership figures would be used for the payer reported figure. Is just kind of the statewide one is kind of the decision point for, where to go.
Yeah, thanks, Vishal. Right. So when we're reporting at all lower levels, we're using either enrolled counts for payers, or for providers, we're using attributed counts, meaning attributed through a primary care relationship. So that's a separate level of spending, because the populations there are more easily defined. and we can directly connect them with the spending in a way that's harder to do at the state aggregate level.
Michael, as you're preparing to move on, I just want to flag we have 10 minutes left before we lose some board members. I would appreciate it if the board's okay with it, that we hear the rest of the slide presentation. If we have a few minutes for additional questions, even if we can't get to all the answers, I want to make sure we wrap up this, and then we will go to public comment. Sorry to the public that some board members will have to see this, the comments later, but as I said, some of us will be here till the end. So Michael, if you could continue.
Yeah,
on
I
the
like to suggest we
last
go
handful.
back to those tables that had the 4 other sources of coverage so we can come to closure. The table that had correctional health system. There it is. It sounds to me like you're saying yes on correctional health system, and we're going to reach out to find out what data we can get for both detail on service spending and on the denominator. It sounds like in general, you want to be all inclusive. Does that mean you want to pursue seeing if it's possible to obtain Indian Health Service spending?
Yeah, I would, and we have some avenues to explore how feasible this is. So I think working with the staff and making some connections to folks at state level that interact with the sovereign nations of each of the tribes, I think we can maybe be able to get some of that information.
Okay, great. All right, and then just to confirm on the next slide, we've got TRICARE, which is about 2% of the state population, so not insignificant. No other state has pursued TRICARE, but TRICARE is not significant in all states. And so that's the reason why states haven't pursued it, and there's no other reason. We would have to explore whether we can get it from TRICARE because their plan administrator in California is not regulated by the state. So we would need their assistance. And then finally, the Veterans Health Administration, there are other states that include it. It's a significant percentage of the state population. Data are available. They're not difficult to obtain. Again, we would have to obtain them probably in an aggregate level and not by service category, but it is possible to obtain California-specific Veterans Health Administration spending. So I just want to confirm, consistent with your overall theme, that you have interest including both of these sources of coverage.
Looking around the room, David, Elizabeth, yes. Ian, I can't see Elizabeth.
Sorry.
The head nod of Ian, yes, okay. Yes.
Okay. All right. So then really I think the last slide that we can get to today is the next one, and we'll have to pick everything up next time. Are there other sources of coverage you want to consider for inclusion? I heard reference to workers' comp.
And workers' comp,
yeah. I think estimates around the uninsured and spending on people who are uninsured, which I know is going to be really tough, but at least to consider it.
Okay, and did I hear Richard say indigent services programs?
Yes, the county is required to provide indigent medical services, so you can get that from the counties.
And who pays for those services? Who administers payments?
The counties. Believe me, the counties do.
But do they get paid for it, or are they just
counties
provided?
supposed to?
We can follow up with you on this, Michael.
Okay. All right. Are there any other sources of coverage to consider for inclusion that we have not discussed?
This is just a question, but if there is an employee of a jumbo employer whose plans are out of state, I don't know how they would be in the count, but I'd like to make sure. Blue Cross of Michigan covering someone in California.
Yeah, Elizabeth, they probably wouldn't be covered because they're not going to be licensed in the state. And so we just won't have a means to get Blue Cross Blue Shield of Michigan to report spending for what would probably be a fairly small population.
So I think lots of points to consider. I don't know, as Elizabeth Landsberg said, I think if there are other areas for inclusion, we can come back on that. We can let each other know moving forward. Yes.
And maybe Michael could at least cover the 2 slides about spending for folks who are uninsured and some uncompensated care, if those could be our last 2 slides in the next 3 minutes.
Sure.
Okay. So it sounds to me like you're interested in capturing this. There are no states that include spending by people who are uninsured because there's no data source. But if you are interested in doing it, we can see if there are ways to estimate what is spending that people make out of pocket who are uninsured. And it does sound like that's your interest. Is that right?
Yeah, I'll confirm that. But again, we understand that the difficulty in figuring out how to do that, but the intent is to figure that out.
Okay.
And if I may, just to wordsmith it, to me, that means not just uninsured, but people who are receiving services that they're paying for out of pocket, even if they are insured and they're covered benefits.
Right. Yeah, I think we captured that earlier. So insured, but paying out of pocket. Okay, so very last slide. And this is here because this question gets raised in every state. What about uncompensated care and bad debt, and specifically charity care and bad debt? Those are 2 different things, obviously. Bad debt is usually for people with coverage, but they're not making the patient paid amount, and charity care is just that. There are no states that include these, primarily because these represent provider costs and not payments. And spending target programs are measuring spending, which is measuring payments. Often hospitals will say you should be including this, but this is a hospital expense for sure, but it's not a payment to the hospital. And in fact, David Cutler, who's an economist on the Massachusetts Health Policy Commission, has argued that, in fact, it is the payments that are subsidizing the uncompensated care and bad debt. So to some extent, that spending is being captured.
Rick.
I mean, if anything, it seems like there might be an argument for subtracting the bad debt out of the estimated health spending, because we will have the deductibles and co-payments will be in the estimates that the payers provide of what's being spent.
Right.
But the bad debt isn't actually being spent. That's bad debt is stuff in which the payers have said, you know, the patient had a $3,000 deductible and we paid $20,000 for the hospital bill. So we're going to estimate $23,000 of spending. But if the hospital didn't collect the $3,000, if that's bad debt, it's really $20,000 of spending, not $23,000.
Yeah.
Everybody looks confused. Maybe that doesn't make any sense.
Not so much confused, but curious how to handle it.
Yeah, it just there's just tremendous administrative complexity in trying to do all of these things. So it's possible, but you would have to get all providers and not just hospitals to report their bad debt and then subtract it out.
Probably a large share of this, I'm not sure of numbers, it would be in the hospital side. So again, would you have to get all providers, or would you, would we have a better estimate of health spending if we at least took out the hospital bad debt? Understanding that bad debt reporting is not uniform across hospitals, and the distinction between that and charity care is not always so clearly made, et cetera, et cetera. I'm not sure if we'd be better off, but at least I think worth consideration.
Yeah, Don, were you gonna?
I don't know how you would, whether this would be an issue, but how inflated bills would bear on this. So if you're,
yeah,
I mean, that could be a real problem.
Yeah.
Yeah, that's the first thought through my mind was the $20,000.
Right.
Somebody made that number. Right, exactly. Okay, I want to just say to the board, no one disappointed. We tried to push the envelope within the confines, despite tradition of other states. I think we did push a little bit. And to the staff and team, thank you for indulging us. Sandra, thanks for being with us. Great. I know other board members may need to leave the room, but if you can stay, please do. And we will move to the public comment section of our agenda, and public comment both on the topic and discussion the board just had or general public comment. We welcome it.
Beth Capel, Health Access. We are dismayed at how this afternoon's meeting has gone with preliminary decisions being made without prior opportunity to comment. And so I understand they're not, but again and again, this board nodded or said yes when we have not had an opportunity to have input. It had been our hope in crafting the law that the tradition that we have at Covered California, where we discuss at one meeting and decide at the next, would be the tradition here. So we are troubled by this afternoon's discussion. It has been, on the substance, a rich discussion. We are also troubled by the repeated representation that there is a lack of data when there are ample data sources available for many things, whether it's bad debt and charity care, which OSHPD has been collecting since at least 1982 for hospitals, or the size of the population and their sources of coverage. So it's a longer list than I have the patience for at the moment of things that we are disappointed in. I would also note we will have comments on all of the topics you have discussed today, including, I'm not going to go through them. I will say language that's included in the law, such as deductibles, copays, and insurance, is standard language in California law. It may not be familiar to people who are not as familiar with California. It is there in part to assure that if the health plans invent another way to dump costs on consumers, that you have the authority to capture that. Similarly, the out-of-pocket spending that's been noted, because dental plans traditionally only cover $1,000 or $2,000 worth of care in a year, or because of the utter failure of our behavioral health system to give people adequate
10
access, is something that we will also provide comment on. Thank you.
Anyone on the phone?
We're noting no raised hands virtually at this time.
Anyone else in the room? Okay, with that, any final comments from board members? Right, seeing none, Ian, just want to thank everyone, board in particular, public who came to join us. Oh, there is one hand? Okay.
We just had a hand raised.
Let's go to the hand.
Hector, you're unmuted. Go ahead. And Hector, you're unmuted on our end. You have to unmute on your end also. Hector, we can't hear you at this time. Hector, we show that you have not unmuted on your end.
Hector, if you go to the top where there's a picture of a mic, if you click that to try to unmute.
Yeah. Hector, we invite you to submit your comments at the email address on the screen.
besides Hector? Anyone else waiting?
Noting no other raised hands.
Okay, with that, we will wrap up this meeting and we will see you all next month. Thank you.